All right, everyone, we are here for another fabulous episode of Sebastian and Sierp. So glad you could join us. We've got a very exciting program today. We're going to be talking to Dr. Timothy Ainger. And I was informed that's exactly how you pronounce it. It's A-I-N-G-E-R. It's pronounced Ainger. And he says he gets other versions all the time, so please use that version only. Anyway, please tell us, by the way, thank you so much for being with us.
Absolutely, my pleasure.
Really excited about talking with you a little bit. Please tell us your official title here at the University of Kentucky.
All right, so I am a licensed clinical psychologist. I'm a clinical neuropsychologist, and my title here is I am an assistant professor of neurology.
Okay. And for those listeners out there who may be, like say they go online and go, let me Google neurology.
Right.
And we know it's to do with nerves, but more specifically, what is it a neurologist does?
The elevator pitch for what a neurologist does is something to do with nerves is probably a good conceptualization. My special niche of neurology, so how I came to be what I do now is I didn't go to medical school. Our degrees are PhDs, so they're doctorates, but they're clinical doctorates. So we came from the ground of psychology. So all of our background training is in clinical psychology within a specialty residency or fellowship at the end of that in neuropsychology. So what I do is we focus on the actual functioning of the central nervous system, most specifically the brain, but sort of how it integrates with the rest of the body from that perspective.
So in central nervous system, you're talking about basically the brain and spinal cord. That's mainly what comprises central nervous system.
Correct.
So when you say that it's from the background of psychology or psychiatry, how does that interrelate with the neurology of it?
Well, we get to have our foot in both camps. The brain is a fascinating organ. And when people say, I don't understand why I need to be evaluated, why my brain needs to be checked, is the pitch line I go to is because we're checking out the part of your body that literally controls the rest of your body. So when something trips up in the brain, it can affect systems across the entire body spectrum, one way or another, directly or indirectly. So when we do our training, we get background training in theory, practicality, therapy, neuroscience, all those types of things. And then when we specialty train in neuropsych, we sort of take a look at the actual functional components of the brain itself and look at sort of special divisions and compartments of the brain and differentiated functions of each particular lobe. And then we can parse it out and say, okay, we're going to do a series of tests to look at very particular functions and how the brain itself is integrated and where things are working here and what not working, what's going well, what's not well, are there any patterns that are emerging that can help contribute to making a diagnosis, things like that.
Gotcha. Okay. So I know that you have a fairly big clinical load as well as your own research, right?
Correct.
You were telling me before it's like 70 or 80% of your day.
85%, yeah.
Is that so? For the typical person that's coming in to see you, are there certain things that are kind of like, okay, that we see this every day?
I would say the common cold of a neuropsych referral, it usually involves memory in some capacity. Here at this medical center, we are very diverse in the amount of and types of referrals that we get. So if I was working out in the community, hanging a shingle in private practice, I'd probably be seeing a lot of pure memory referrals. But memory seems to be impacted with a lot of different diagnoses that get referred in. But whether or not we're differentiating a primary memory disorder, like if it's an Alzheimer's situation or a dementia or something like that, versus memory is impacted, but it's secondary to injuries from a traumatic brain injury or something like that. So there's always a bit of a memory component in a lot of the testing that we do, and we'll tap into that. But I get a pretty diverse referral base from the clinicians that we have in-house. The majority of our referrals come from our neurology faculty, the practicing MDs. And then I have some specialty clinics for patients that I'm working with, working on a couple different teams here in the hospital. And I wouldn't say prioritizing, but seeing them because we sort of have a track for their care, and other community referrals that come in as well. So we get patients who are being evaluated for epilepsy management, or I see patients who are getting organ transplants, multiple sclerosis, dementias, concussions, things like that.
Gotcha. So yeah, and a lot of people, I think, don't realize it, but things that are pretty prevalent, like Alzheimer's, Parkinson's, and so on, those are indeed neurological issues, right? Mm-hmm. I mean, because a lot of people just think, well, it's a brain thing. But
It's a neurological disorder, right?
so when you see something like Alzheimer's, for instance, is that like the disintegration of that area of the brain that would deal with?
Well, there are primary areas that we associate clinically with Alzheimer's, and there's a lot of biomarkers that we would look for. Biomarkers being actual biological antecedents to the disease process. So we could say, oh, this is a red flag and it's concerning for this. And they can happen on the chemical level, whether we're looking for a particular type of protein when we look at cerebrospinal fluid. They can happen on a more organic brain parenchymal level where we do MRI imaging and we can say, oh, we're seeing sclerosis of these particular regions of the temporal lobes, the mesial temporal structures, or on a cognitive functioning level where we say, look at the fact how within normal limits the rest of this testing is, but there's a pretty predominant problem or concern within the memory domain. So there's a bunch of different ways that we can look at it and see where that pattern is going and where it's taking us.
So I'm assuming that there could be breakdowns like that in other areas of the brain, but if we have like one area or one group of areas, then we'd say, well, it's affecting them when we call that Alzheimer's.
Absolutely.
And then here's this other group and we're calling that Parkinson's. And then maybe one person comes in and I've been having problems with incontinency and because the brain's been affected. So is that?
Yeah, and I mean the
There.
incontinency is a bit. It's funny because there's a couple different conditions where that really plays a key role, and it's a key factor or it's a secondary change. The Alzheimer's one, it's a neurodegenerative process. So over time, it's going to disrupt a large portion of area in the cerebrum. But overwhelmingly, the biggest red flag that brings people in for an Alzheimer's referral is memory change because that's the area predominantly affected. Versus like a frontotemporal dementia, where it's not going to be a pure Alzheimer's style pattern. It's going to impact frontal lobes and this area that we call executive functioning. We'll get into that a little bit later because that's sort of a passion of mine. But then structures that are involved in other disorders too that don't follow a similar process. We sort of have to look at all the data for. There's behavioral patterns for things like Parkinson's disease or dementia with Lewy bodies that don't quite present the same way, and we sort of have to follow our hunches and gather different pieces of evidence and clarify things because there's some of these can be really finely tuned. What's the difference between this and this? Oh, it's a very minor thing that we can pick up on, and we like to work with our referring providers and help them suss it out whenever possible.
Yeah, because I would imagine that when someone comes in and you're just like struggling to find the right diagnosis for them, that some of them being so similar, it's like, it may be even easy to misdiagnose sometimes, or like this presented so much this way, it must be this, when in fact there was one little area that was different and therefore, oh no, wait, it's this.
I think it gets really frustrating for a lot of patients because oftentimes, especially by the time they get to, a lot of patients don't come to me as their primary referral source. They've seen a neurologist, they've seen their primary care provider, they've seen their family doctor, and they get referred to me where I work here. So it can feel like it's just another, I had the MRI, I had my CT scan, I did a lumbar puncture, I saw my neurologist, you're just another appointment. And it can be frustrating to sort of get lost in that process of another doctor, another referral. And I think the thing that I want to keep in the back of my mind, and I want patients to keep in the back of their mind, is we're being cautious, not because we don't want to be aggressive in treatment management, but if it's a situation where we can parse out two very similar disease processes that would have different treatment modalities, we don't want to make that error. So we're going to provide the best care we possibly can, but at the same time, we don't want to send patients 6 months down the wrong treatment path if we can make the correct diagnosis at this juncture and then send them in another direction that's the right one.
Sure, and that's got to be tough because when people are coming in and they're like, I don't know what's going on, but I just want it fixed fast.
Exactly.
And then, so there's all that urgency for them, and then on your all's end, you're like, look, we got to do consults with other people,
and sometimes there's not a quick fix. Sometimes there is, but oftentimes there's not. And
Yeah.
that's one of the tricks about working in this field is that sometimes we deal with people for whom the fix is not really a fix, it's a management.
Okay.
And that
So like we
that's-
caught it and we're kind of keeping it this baseline, but that's about as good as it's going to get.
Yeah, we're going to manage it as long as possible. My personal philosophy with patient care is that I want to keep you as happy and as healthy and as independent as we possibly can without causing risk and causing disruption and harm. So a lot of times people come in, they get evaluated, and they're afraid they're going to get a diagnosis, and that's going to immediately mean, well, we have to be moved into assisted living, and it's hospice care, and they're taking my car keys, and they're hiding my knives, and we need to see where a patient is And then we can even evaluate periodically as the years go by and see kind of what level we're at. Are we progressing rapidly? Are we progressing a little bit more slowly? What kind of recommendations do we need to make? Because especially if you're dealing with a neurodegenerative process where things are going to continue to progress negatively as time goes by, stability can be very reassuring for patients. Making rapid changes can be very confusing. So uprooting someone who's in a slightly to a more confused state or a little disoriented can be very frustrating. And that affects their overall well-being as well. So kind of minimizing the rapid changes and making sure we're managing people and keeping them healthy and keeping everyone safe, but not turning their world upside down aggressively. It's what I like to keep in the back of my mind, which kind of minimize that risk as much as possible.
Well, I'm sure there's a huge mystique that creates more fear about it for people to come in. Maybe they've had some memory loss and then immediately they jump to this thing. Well, I must have Alzheimer's and this is going to be my fate because I knew so-and-so with Alzheimer's and it must be what's going to happen. Oh, God, I just can't hack it.
Everybody knows somebody who had this thing, right?
Sure.
So when I meet with patients, I like to reassure. Well, you can tell when someone is sort of having that. Some people come in and I've been carrying this diagnosis for years and years. I know what it is. I'm just here to get a checkup. But some people, they're concerned that something is going on. There's unclear evidence. They don't know what's happening. And you can tell them, well, first of all, we're not the bad guys because this would be going on whether you came to see us or not.
Right.
We're just, if something is happening, we're going to put a
We're in the
label
line
on
of
it.
fire.
Exactly. But, I mean, at the same time, there's things that happen with, if it's an aging disorder, there's healthy aging. And people who are really in tune and they sort of notice minor changes can get really freaked out. Oh, I lost my wallet a week and a half ago. Is this the end of my memory? And you can sit them down and say, no, you're just not 22 anymore. The testing came out, pretty much normal. It's okay. Get used to being 67 at this point and walk them through that. And it's a little, I can see the sort of relief come over their face and the blood goes back to all the places it should be, out of their cheeks, and they go, oh, okay, well, that's frustrating, but I'm glad to know things are normal.
Right. Yeah, there's a thing about normal that's reassuring,
right?
I think, for people, yeah. But yeah, it reminds me of guys that might say, well, I used to lift weights and I used to bench 250 or 300 or whatever it is, and then, and then they don't do it for 40 years and say, well, let me go bench 250 and then wind up shredding their chest or whatever.
I like to talk with people using analogies a lot. And I think it's just it's characterological for me because it helps me sort of, when I was learning this material years and years ago, it sort of helped me understand it that way. But also, I don't like it when people come in and they've seen 15 physicians and they can't give me the elevator pitch, that sort of 2-minute pitch of what's going on, because they don't know. Because they've been given doctor speak and technical jargon and they don't know what these things mean. So meeting patients on a level they're comfortable with and sort of discussing things with them, analogies are very helpful for me. So one of the things I talk about is, we are going to look at you, but when we look at what your scores come out to be and how we're going to compare them, we're going to find scores that are the best possible picture of where you are as a person. We're going to look at your background, your education level, your ethnicity, your all these other factors that could play into it. And I tell them, when we were 19 or 20, maybe we could run a mile in 8.5 minutes, 9 minutes. Now that you're 75, should I put you in a foot race with someone who can run a mile in 8.5 minutes? No. Why not? Because naturally we wouldn't expect you to perform at that same level. So we're not going to, there's no one score where if it's below X, it's an automatic failure. No, we have to look at all the data and look at things on a spectrum and look at people as a process and as a system as a whole. So it's, people do this as, well, my friend did the same thing and they ended up with X diagnosis or X disease. That's your friend, that's not you.
Right. Yeah, people are so individual, there's no way you can quantify them together in any way. There's no way. So.
And making that accessible to people. And I really like it when I get to have the chance to explain something to them and I can see the lights come on.
Yeah,
and say,
these
are the words you've heard for 3.5 years of appointments with outside physician or whomever, and understanding what that means. And oftentimes when I sort of talk with patients about, well, these are things I might understand or might expect, and they go, oh, that's why this has been happening, or that's why, I do have that sort of thing, and now I make that connection. And it takes them from being an uninformed patient to whom these things are being done to an informed consumer who is an active participant in their own care. And that's the best piece of advocacy.
So they're
that I
part
can
of the
put in.
team and
Exactly.
not the focus of it.
Right.
Gotcha. Hey, folks, we're going to be right back here in a moment. Sebastian Sier, we're going to take a quick word, and we'll be back with Dr. Timothy Ainger.
At Kyojuteru Kempo, we believe that everyone has the right to defend themselves and their loved ones. Violence can visit us despite age, race, or gender. Call us at Kyojuteru Kempo or check us out at kyojuteru.org. kyojuteru.org.
Hello, I'm Chip Sebastian. I am the co-host of Sebastian and Sier. If you've been liking the shows, please click like down below. And if you want to subscribe to our YouTube channel, jump on over to YouTube, click subscribe, and you will get the most recent episodes of our show where we're interviewing all kinds of great and interesting people. So we're looking forward to a lot more shows. Stay tuned. It's rolling. Just begun. And we're back. Hey folks, we've been here with Dr. Timothy Ainger. We've been having a good time. He's telling us all things good about neurology and how he's helping many, many people. I wanted to talk to you a little bit about just the process that happens as we age. I know there's this thing with like telomeres changing and DNA and things like that, but what is the reason that the nervous system sort of breaks down over time? I mean, is it just entropy in the universe in general, or?
It's the natural aging process. I mean, trees grow up and leaves fall off, and flowers grow and wilt, and so does our body.
It's just that simple.
It's the same reason that my great grandmother lost 7 inches when she was 80 years old. It happens over time. But there's a deeper explanation to all of that as well. When you look at developmental medicine, we're born with all the neurons that we're ever going to have in our brain, and then we sort of lose some of it. Now we continue to make connections between neurons as time goes by, and we learn things, and these different areas of our brain connect with each other and make associations, but we're not making any more neurons. So
So the neurons are finite, but they still connect.
Right.
And even if you were 100 years old, you could still do things that would help them to connect better.
There's so many factors that play into it. There's genetic conditions, there's environmental conditions, there's other biological factors, there's other health factors, there's things that are beyond our control. When you sort of look at all the things that can play into being a person, that's why you have to look at all the pieces of evidence. Just because someone is genetically predisposed for a certain condition to express doesn't mean that that condition is going to present itself. There's very few conditions where there's a one-to-one correlation between somebody's parent having something and them having something. Oftentimes, the environment or the conditions that you come up and sort of have to play into that and express those factors. There's the diathesis stress, or the stress diathesis model, depending upon which textbook you're reading, sort of speaks to this. But it's you're a product not of nature or of nurture, but it's nature and nurture working together. So, to make a gross example out of it, if someone is genetically predisposed in their family to have a high incidence of alcoholism, okay, they're not going to be an alcoholic if they never drink alcohol.
Hard to do.
Right. Same type of thing when you talk about other disease processes. So those factors could be existing there, but they may not ever express themselves if something doesn't trigger them, start them, whatever. Now, it's a little bit more complicated because there's not a lot of neurological conditions that are sparked by, alcohol or something like that. There are some, but not something that simple.
Okay.
But we sort of, all the factors that play into it, in normal aging, we expect there to be some cerebral volume loss. Your brain is going to get smaller as you get older. Now, it's a very small measurement, but it's one of the things that we look at, especially when we do neuroimaging in our elderly patients. We can see cerebral volume loss, but within the expected range based on the patient's age. That's okay. But when you see the way that it's aging, and you can see the differences in the sizes of different regions of the brain, then you can start to say, well, this is beyond what we would expect. Something may be going on here. There's a little bit of sclerosis in this region, or there's a little bit of entropy here, and that can
By sclerosis, just for the viewers, what is that exactly?
Well, when we talk about sclerosis, we're talking about areas of the brain where there's some type of particular shrinkage or lesion, things like that. And it sort of plays into itself from different disease processes. So when we talk about, say, multiple sclerosis, okay, we're talking about sclerotic lesions and areas where there's changes in physical structural changes and shrinkages, versus if we're talking about imaging for a patient with Alzheimer's disease. We look for mesial temporal sclerosis, which is the area on the inside of your temporal lobes will shrink and get smaller as the hippocampi get smaller. That's the biomarker we look for there. So what we're talking about is you have all these neurons, you're making connections, that's the learning process, but you go through, as you develop at a very early age, your brain starts to sort of prune and say, well, we don't need that connection here, we don't need this connection here, and it becomes a very well-oiled machine as these connections sort of, they start to make with each other and different parts of your brain link up. And it develops in these portions of your brain, the very basic skills, they develop very quickly, and then there's portions of your brain that don't fully develop until you're, a late teenager. The one that sort of develops the last is this whole concept of the frontal lobe, which is responsible for our executive functionings, our behavioral expression, processing speed, paying attention, focus, vigilance, things like that. But the behavioral expression is the biggest one. So that's the area that sort of kind of finishes developing at the very last stage. And it generally happens around sort of that late teenage years. So different parts of the brain develop at different speeds and rates, and then they sort of dissolve and atrophy at different rates as well.
So is that it developing, the executive center, that is, it developing at the sort of the end of your adolescence, or, when you're right before you would say, I am an adult now.
Sure.
Right? Is that a result of just the way that it happened evolutionarily? I mean, in terms of, hey, you got a brain stem, and now you got, your optical centers and all this, but this kind of developed over that way.
It's the part of our brain that sort of separates us from a lot of other animals that either have a very underdeveloped region or don't seem to have those similar functions that we do. And it's just sort of kind of the way you painted that picture, brain stem and then optic centers and forward is a rough way of conceptualizing how they sort of develop. And it's when you see time-lapse graphs where people have sort of colored activation centers over the course of human development, it sort of is the brighter colors come forward and then finish off the front of your brain at the...
Well, that's wild.
Yeah.
That's really wild. So, and I've heard and seen fictionalized a number of times where someone may have some kind of damage to their frontal lobes or the front of their car accident or something, and then all of a sudden their personality changes. Like they don't have these executive decision-making qualities they once had. And that's one of your fields of expertise, right?
It is. It's something I'm very passionate about is executive functioning. Sort of the hallmark case, every Psych 101 class will go over this, exactly. The Phineas Gage story. Right. So, and somebody's going to yell at me, one of my professors is going to see, and I'm going to blank on what year this happened, but he was a railroad worker.
Like 1800s. Sometimes.
Yeah, and his job was, when they were excavating and driving railroads to lay them across America, his job was he was wielding a tamping iron. So it's a long piece of metal and a hammer, and what he would do is be tapping dry explosives into the ground. Well, there was some moisture apparently in the explosive material, and when he struck his hammer, it caused a spark, and it set off this explosion and shot this 6-foot-long metal rod through the base of his jaw and out the top of his skull, which would be a devastating injury, but he miraculously survived. But what we started to notice was, like I was there, what the field of psychology...
You don't look that old, man.
The burgeoning field of human science began to notice that he was having these wild behavioral changes, and he was no longer the man that he once was, and he was completely disinhibited. He was getting into fights with people and doing violent, vulgar things. And the stories differ from who you have. He had marital discord, and he would get into bar fights, and he was a vagrant at the end of his life. I think at one point in time he was a circus exhibit or a sideshow exhibit, and you can still see his skull and tamping iron to this day. They're on display at the Harvard School of Medicine Library in Boston. But yeah, that's one of the things that kind of went, wait a minute, maybe there's something to this whole front of the brain controlling behavior philosophy, and that sort of paved the way for understanding of functional neuroanatomy, and that moved into people doing in vivo experiments during brain surgeries and determining, where language centers are, where motor strips are, and that led its way to brain surgeries in the 30s, 40s, and 50s, where we were intentionally cutting various portions of the brain.
Frontal lobotomy.
Exactly. And what kind of affective change we can bring about there to our more contemporary understanding. And there's this whole Dunning-Kruger effect of what we know about functional neuroanatomy. There are finite areas where we know this spot does this thing, asterisk, with the following exceptions, it may not. But the frontal lobes are almost like the last frontier of this. It's a little bit more abstract as to what we know, the functions that are pretty much there, but it's a lot harder for us to go, this square millimeter does this thing, because it could be different per person.
Which is why during a brain surgery they would take off the skull cap and actually map the brain prior to. Right?
Depending upon the type of surgery and the type of outcome that needed to do, we can do some brain mapping like that. And that part of the brain is very sensitive to insult or injury. Insult and injury being some type of change, not like somebody calls you a bad name insult, but like if something actually happens to your brain, whether it's a chemical change or you are having some sort of loss of oxygen or you're not getting proper blood flow, all the way down to traumatic brain injuries and things like that. It's very sensitive to that. And my dissertation looked at executive functions, the sort of frontal portion of the brain, and we looked at individuals who were inpatient and had been diagnosed with chronic paranoid schizophrenia, because at that point in time, I had been working with a lot of patients who had this diagnosis. And I noticed across the assessments we were doing, there was a strong pattern of executive functioning changes. The problem being, we would give these standardized tests and compare them to age-matched norms. Okay, you're 65, you're 25, we're going to give you to the correct norms and compare it and see how it comes out. And they would perpetually be coming out in this very bottom of the group. But there's a lot of variability in-house with functionally what they were able to do. There were patients who could understand the rules of the facility, were able to take their own medications, were able to have grounds privileges, didn't need to be supervised as much. And there were patients who absolutely needed hands-on care. And how was that expressing? So we said, okay, compared to the general population, we accept they're going to be down here. But let's examine the variability that's occurring here. And are there variables that factor into this? Does it matter age of onset of when the symptoms began? Does it matter how long they've had the disorder? And when we establish a trend, and we actually noticed there was a normal curve in that population. There were people who were weaker of weak and stronger of weak, and what we found was there were correlations between those were the people unknowingly identified by hospital staff as higher functioning, can do the things. They don't need to be supervised as closely. They can be working for the facility. They can participate actively. They can help coordinate groups and coordinate meal times and things like that. They were the ones who had stronger executive functioning scores.
So the schizophrenic model can go from like beautiful mind, where you're still functional, but you've learned some skills to deal with whatever happened during your schizophrenic break, which is, those usually happen somewhere in the 20s to 30s, right?
I think the contemporary knowledge is a little bit earlier for males, but sometime in the late teens. Yeah.
So, but definitely not during formative years,
right?
Where you're, really learning, hey, here's how I eat with a fork and stuff.
It gets very fuzzy down there. There's a lot of, I don't want to say politics, but there's a lot of debate in the psychology profession as to sort of how we're going to define schizophrenia and psychotic breaks at a young age, because younger children they can't express themselves on the same level as
adults. They may not present in the same,
exactly.
Right. So they may have a break and just internalize that whole experience. You may not even know what's going on. It just seems like little Johnny is seeming like he wants to be off in the corner by himself and not playing with the other kids, whereas here's a 25-year-old guy who flips out. And
but on the other end of that, what's a psychotic break and what is just imaginary play?
Right.
This is my imaginary friend Steven. Okay, that's great. Now, if that expresses in a 38-year-old, that's a little bit different, but like a 7, 8, 9, 10-year-old, that's par for the course.
So really, that's sort of a label that doctors and science and medicine has had to put on that. But, if you were to examine Johnny right at that moment, that maybe his behavior changed a little bit, or it seemed a little different than the other kids, or whatever it is, you might say, well, we're actually looking inside and we see chemical changes that are going on that lend to what we wouldn't see in a schizophrenia in childhood.
This is why in our little corner of the world, in our corner of neurology or psychology, we're called, we call ourselves neuropsychologists because we have a foot in both camps here. It's a science and it's an art at the same time. So you can't live and die by what the numbers say, and you can't live and die by what the test results are, because numbers lie all the time.
Right.
You can manipulate and change things. You have to understand what a score means, what a performance means, how it correlates to behavior, what patterns are emerging. Yeah, we can get duped by an abnormal presentation every now and again, but by and large, we're very, very cautious with that sort of thing, and we can say, something's going on with that score, something's going on with that number, this is not lining up. And that also plays into, when we look at patients who may be overindulging some of their symptomology and things like that, and how we can suss some of that out.
You mean as far as like they're playing it more than it is, you mean?
Whether it's intentional or non-intentional, right?
Yeah, so they've bought in, so there's some kind of placebo effect in the sense of, I have this, but I'm inflating it to this for attention or whatever.
Or for whatever the gain may be, exactly,
Yeah.
right.
I remember years ago when I worked in the ER, they used to call people gomers. Like, get out of my emergency room, because they'd come in and you'd have like 200 of those people, and then one guy who was really sick, and then, but we got to get through these people, so like, get out of my emergency room. Your field, it seems like some parts of medicine and science are very, very, like, this is just the way it is. Like, if you were, say, a medical chemist, and you just said, well, here, I'm writing this, and I send it over to Germany or whatever, and this guy gets it and says, oh, I'll replicate that.
Yeah.
But it seems like for your field, it's almost like doing the Myers-Briggs, it's like, well, it worked for this person, or it seems to work for this person, not this person, it seems to. So, there has to be a lot of consultation going on with your colleagues and stuff.
There's a lot of consultation. We have areas where we can kind of bounce ideas off of each other and ask questions and whatever, but there's so much of this that gets to be cultural, because at the core of it, we're all psychologists. The neuropsychologists, we're all psychologists. So if it was a blood test and we drew your blood and it said, okay, your blood glucose is 107 milligrams per deciliter, great, fine, that's a finite finding. Mm-hmm. Or if we said, give 12 rats 3 milligrams of this 12 times a day, that's easily replicatable. But so much of psychology is cultural. When these diagnostic manuals, like everybody talks about the DSMs, the diagnostic manual, right? That's produced by the American Psychiatric Association, the American Psychiatric Association.
Right.
What we consider to be culturally normal or culturally aberrant is something that another culture may consider to be the vice versa of that. Mm-hmm. So that's something we have to take into account for a number of reasons, not the least of which, it's in a way I conceptualize food. When people say, oh, I can't believe you'd eat that weird thing. Well, somewhere in the world, this is a normal food to somebody.
Right.
So somewhere in the world, the behavioral expression that we're seeing might not be conceptualized the way we're conceptualizing it or typically would. Mm-hmm. Someone from a different culture, this may be expressed as X, and we're thinking of it as Y, but it's actually, there's more to it. And that's the way that they're expressing it, or the language that they use. And it's important for us to keep that in mind when we're looking at people from either foreign cultures geographically, or foreign cultures because of a condition or a diagnosis or a lifestyle, and how those things all present themselves. So I would give you a perfect example. My last Terminal 2 degrees came from Gallaudet University, which is a national university for the deaf and hard of hearing in Washington, D.C. A lot of the tests that we give, well, some of the tests that we give have a verbal component to them. Mm-hmm. I'm asking you to tell me words, or I'm asking you to say things to me, blah, blah, blah. If you grew up culturally deaf and you don't speak the English language, on those measures you would score very poorly. Mm-hmm. It's not because you can't do the skill that I would be assessing if you were hearing. It's because you just can't do the mode of expression that I'm asking you to do it. Mm-hmm. So if we can find a culturally accessible way for you to express that information, that score will be completely changed and conceptualized. Why you can't live and die by the numbers. Same thing happens when we think about some of the tests that we give. They have stimuli, and I'm trying not to give a lot of this away because we're going to ruin the validity of all of our tests, but there's stimuli that could be culturally bound. Mm-hmm. If I'm asking you to identify or express or explain something that from this culture, whatever my culture is or whatever, but it's something you've never been exposed to, I can't hold you responsible for not knowing something you've never known. if you can't learn it or if you've never been exposed to it. So something to keep in the back of your mind. And when I teach medical students how to do brief cognitive evaluations, this is something I go into in detail with them. If you're asking them to answer some question and it's knowledge they've never had, they can't be held responsible for not remembering it.
Sure. Right.
And you have to think about that across cultures. And that's one of the biggest things that I like to think about when I practice, is that it's sort of this adaptive neuropsychology. How can we take what we know, the processes with which we're familiar, and the conceptualization of science and how we do it, and how does that apply to each individual person? What makes them different, and how do we need to understand that so we can provide them with care, and how do we need to make it accessible to them so they're getting the treatment they need and the understanding of what's going on?
Right. Well, and I could see that not even being just America and then outside cultures, but even within America itself. I mean, because you can have people that have totally different thought. I mean, if you take someone from say Baton Rouge, for instance, that's a totally different culture
Right.
than upstate New York.
Right.
And so it could be that even within, I mean, because I almost think of our states as small countries in the way Europe is set up.
That's exactly right.
Yeah, because it is just, I mean, even like a Kentuckian and a Tennessean there are some real different, and I don't mean just sports, I mean.
The easiest way to look at that is when we talk about education. Kind of a big benchmark that gets overlooked in our field is people just say, how many years of education do you have? This is the first way we're going to start to suss things out. And it's to help the patient, because we don't want to take somebody who has 3 years of education and then worked for their entire life and normalize them against someone who has 4 PhDs. That's a different threshold. Right. So we're going to look at the scores differently. But you also have to think on a clinical level, what's the quality of education and where does that education come from?
Absolutely.
Right. Is every person who says they have a high school diploma, is it from a private, school in Boston? Mm-hmm. Or is it from a rural one-room schoolhouse in South Dakota? Mm-hmm. Or were they homeschooled and they earned a high school equivalency? Mm-hmm. Do all those match up? And if not, what does that mean for our understanding of what they're going through? And when they earn these scores,
or maybe they graduated from a very prestigious school, but they had horrible grades. And maybe somebody else went to a level 2 school or whatever, right, and they had straight A's.
That's just one way. That's just one example of how you have to look at this. You have to look at the person as a person and not a number and not a variable and not a denominator.
Yeah, it's so vast and complex. I mean, you just can't. To me, that's one of the huge things about science and the Enlightenment in general, is just that this attitude of no prejudgment. No prejudgment.
Right.
And we can hypothesize, but we know it's hypothesis. It's not, I have already said that's the way that is.
Right.
And therefore it must be true. And anything I think from here on out is going to make that true, because that's what I want to see.
It's difficult when you get, when I get my caseload for the next week and I see where the referrals are coming from. I have to know what's coming in the door so I can prepare for it. But you also have to be careful and say, okay, this physician says this patient is diagnosed with this, but I can't walk into the room and expect them to behave or act or test a certain way. Mm-hmm. I have to sort of allow it to help my conceptualization to a point, but then be able to separate that information and allow the patient to be themselves, mm-hmm, and get their individual experience, mm-hmm, and then let that go into how I'm conceptualizing.
Well, and that they're probably in an altered state just coming to see you anyway.
Very possible.
Yeah, I mean, I know, my mom is elderly now, so when I take her to the doctor, which is about once a week these days, right, most of the time her blood pressure is a bit elevated from what it normally would be. And it's because she's been walking upstairs and she's, mm-hmm, coming to see the doctor, and I really don't want to go see the doctor and all that. And so I can imagine that psychologically, when people come to see you, they'd be the same. And it's like, what if he tells me something bad? Oh, God.
That's right. It's not just biologically altered or biophysically altered. It can be psychologically altered, affectively altered, all those types of things that play into it.
Mm-hmm. Yeah, that's really amazing stuff. I was going to ask you, so with what you're doing, you deal mainly with the central nervous system. Do you have things that you deal with as well in the peripheral nervous system does that play into it? I mean, and can diseases start in one and then migrate into the other or affect the other?
Yes, is the tricky answer to your question here, because when you look at the nervous system as a whole, central nervous system, brain, spinal cord, mm-hmm, peripheral nervous system, entire rest of the body, and how those nerves are integrated. And you want to look at, because there are disease processes that can affect periphery, can affect hands, feet, sensation elsewhere, and you don't want to miss a subtle symptom because you're focusing on, brain functioning, a spinal cord injury, something like that. So if you're talking about someone who is experiencing relapsing remitting multiple sclerosis and they have peripheral sensations, or someone who has like a fibromyalgia and they have reduced sensation in their hands or feet, or someone who is looking at a demyelinating condition, an acute demyelinating condition like Guillain-Barré or something like that, and they are experiencing progressive paralysis and it's rapid. Now you can manage that and they can oftentimes get that functioning and sensation back, but you don't want to ignore peripheral systems for focusing on those types of things. But beyond that, we work with the mind, but you can't ignore the person and all their symptomology as a whole. So I will ask about things like vision, hands tremors, feet numbness, tingling, things like that. Just you look to see if there's some sort of pattern or progression. And we have fabulous neurologists on staff who are medically trained who will do those types of things, and they'll do EMG tests for the skin and things like that. And we'll get that data, or if we feel like we need to get that data, we'll send out to them for those types of tests. Just depends on what's coming in the door and what we need to be looking for.
Mm-hmm. But I'm assuming that things that start in the central nervous system, like diseases and such, would definitely affect the peripheral nervous system.
It depends on the disease process.
In whatever way.
Right.
Yeah, it would be. So really you're just looking at the whole thing, trying to piece the puzzle together and see what's really going on here.
I call it the systems approach. There's in psychotherapy, the systems approach is you look at the family system as a whole. Okay, so there's an individual who's being treated for this type of thing in therapy, but how's it affecting their mother, their brother, their sister,
Like
their husband, their kid?
constellation.
Exactly.
Right.
And it can be no different when you look at a patient. We want to pay attention to this thing you've been diagnosed with that may be right here in your brain, but also how is it impacting not only your body, but your ability to do your job, because you're now experiencing changes in your hand sensation or your feet and things like that. And where do you do for a living? How is it impacting your ability to drive, function, walk, balance, talk to people, push buttons on an assembly line, write or type, things like that. So you have to look at the whole system and how a disease process or a non-disease process, whether it's just within normal limits, how that's affecting people.
Well, yeah, because I could see, and a lot of this is just from teaching people for years, doing dance and martial arts, where they will start to hurt. And you start to get a little older, and you're like, man, it's not as easy getting out of the chair anymore. And picking up this cup is kind of more effort. What happened? And so that'll happen, and then there's this gradual decline in activity, exercise. Hey, yeah, I think I will go for a walk tonight, all that sort of thing. And then over time, it seems like that leads to greater disease in the central nervous system. I know.
One may beget the other, one may not. Are you not doing that activity anymore because you can't and it's painful, or are you not doing that activity anymore because you don't want to, aren't motivated to, and that's a symptom of something else altogether.
Right.
There are some things that start in other parts of our body that are the red flags that people notice. If someone is concerned about the presence of a movement disorder like Parkinsonism, they may notice a hand tremor, right? That's not something that you wouldn't see a hand tremor per se on a memory test, but they would notice it.
Gotcha.
And okay, well now let's see if there's that cerebral pattern that we're looking at here. So there's all types of things that you may be picking up on.
And then in the case of Parkinson's, they also have the freeze that goes on too, right? So, would that be something that would present where maybe the person just is stuck and can't, feels like they can't move? Or?
It's a bit trickier because that one is one where we need to look at all the biological data, the imaging, the neurology referrals, their changes over time. How have those symptoms progressed? How have they changed? What's the pattern? As well as the cognitive symptoms. There's a lot of cognitive changes that we sort of expect to occur in different stages of those diseases, but it's not always a guarantee. Some people just function differently at different stages than others. So it gets tricky when you say, oh, they're experiencing X, Y cognitive changes. Is that due to the diagnosis of probable Parkinson's? Is that something separate, and we're actually looking at two concurrent conditions that are occurring simultaneously? Or is this normal, and it's due to the affective changes they're having? Is it due to the fact that they're severely depressed because they have a disease or they're concerned about having a disease or disorder, and that's what's causing things?
Yeah, so like the psychology of it definitely it's like a volleyball going back and forth,
Exactly.
Physical, psychological, back and forth, and then if the ball starts to get lower and lower and lower, eventually it's going to drop. And
Right,
yeah.
and one sort of begets the other, and you can get into that downward spiral progression. That's one of the things that we're looking at in one factor of my research as well.
We're going to talk about that right when we come back. Sebastian and Sierp will be right back, folks, with Dr. Timothy Ainger.
There's something about my house that holds the past. My body holds spirit in similar stead. Memorizes in cells with potential flame, ghosts of the worlds by flesh and bone fed. The walls of this room are my heart's strength, the sink my blood that flows with fire. The bedroom holds my resting bones, the brick my flesh and fair attire. I was a boy who lost his way on the winding wood of spirits slain. No memory, no fair words portray on the glade where kings and princes reign. A castle under the silver moon hovering by the sea that pounds below the thundering sky to infinity. A maiden in the castle keep, her hero in the moat. A girl who for her lover weeps, armed guards in every boat. Find these poems and many more at lulu.com, L-U-L-U, lulu.com, under Charles Sebastian. Charles Sebastian, Seasons of the Centaur, available at lulu.com.
And we are back. So happy to be here talking with you, Doc. I hope you're having a good time.
Having a great time.
Yeah. And I wanted to, so you were starting to talk about what you're doing currently with your research.
Yes.
Now, do you have one big research project going, or is it a slew of things?
I have multiple research projects going. Some are getting a little bit more attention than others, and that's, there's only
By that you mean in the press, or you mean?
Oh, I mean in my own personal, how much time I'm able to do.
how much time? I got
There's
you.
only 48 hours in a day that I can work, right?
And you use 47 of them already.
I've tried. There's a couple different areas that we're looking at in different avenues. So one of the things that's getting a lot of attention right now is a very practical application of our research. There's some friends of mine, some colleagues that I have from my involvement in the forensics world. I have a lot of training and background in forensics and different avenues that I've worked in, places that I've been consulting with. And what we are concerned about is there's people in that environment, forensic professionals. Now, we're getting a lot of attention right now from police officers, detectives, and sworn enforcers of the law who are suffering from depression, anxiety, PTSD. And they are at risk for harming themselves or harming other people.
Wow.
Beyond that are the people who work in forensics in a supportive capacity who are not getting that spotlight and that attention. Crime scene analysts or video data techs, or the people who have to analyze and process a crime scene.
So they're being overlooked in this regard?
I want to be very careful when I say they're being overlooked, but the resources are stretched very thin and people are not getting access to them, or we're just beginning to sort of get an understanding of how it's very obvious to say we have an officer who is involved in a shooting or an officer who was shot. Very likely they may develop some sort of issues related to that. Let's provide them with all the services. But when an individual's career is to perpetually scrutinize, collect, analyze, observe, view traumatizing information, things that it becomes less of a if something happens to a when something happens.
Yeah.
And we start to see a lot of individuals who are in this field who leave the profession or require treatment for some sort of emotional disturbance because just the sheer day in and day out of what they do is so emotionally exhaustive. And they are at great risk for, at the very least, leaving their job that they've trained years and years and years for and sunk all their money. And at the most risky one is that they're concerned for they're so depressed that they may take steps to harm themselves or others. And we've sort of been looking at a lot of the data. It's become the statistics of how often this is happening, why this population is not getting that sort of attention, and it's just because really not a lot of people have taken a look at this specific subgroup at this point. The resources to even analyze it are really thin at this point. And so I work on a very small team. Two other people that I work with, one is Dr. Amanda Farrell, she's a PhD in criminal justice and criminal studies, and she is actually training to become a counselor as well. So she's out of another university, and she and I met doing forensics work together. And then retired Detective Christopher Scallon, who has actually developed a treatment center where he works with individuals who have had affective concerns or PTSD and things like that. And we've begun putting a project together where we can analyze on a grand scale the emotional implications of doing this work. What is the burnout rate? What is the concern rate that we have for these individuals? What symptoms of depression and anxiety are they experiencing that they may not even be aware of? And then beyond that, neuropsychologically, how is that impacting their actual cognitive performance? We know, based on research and studies, that when individuals have severe levels of depression, anxiety, emotional disturbances, bipolar, schizophrenia, things like that, their cognition gets impacted because of that. But we don't know quantitatively or qualitatively individuals who have not had those diagnoses because they've not been participating in research studies, because they've not been tapped as patients. And to what level are they suffering at work? To what level do they need services? And how can we not only help identify it, shed some light on what's actually going on there, but then make recommendations at the individual and agency level for how we, in the forensics community, can begin to better care for our professionals.
Like taking care of them on the job instead of waiting until, these people seem like they're getting ready to burn out and crash. And so kind of prevention.
And the big thing that plays into this is that no two people are exactly alike, as we discussed earlier, and no two treatment modalities work for the same person. So a big sweeping agency-wide recommendation. I'm going to pick on yoga, which I don't mean to do because I actually yoga's great. But if the agency comes down and says, "Oh, are you traumatized? Do some yoga." That may work for some people, it may not work for other people, and we're not providing adequate resources, attention, whatever needs to be done. So, we've been giving this presentation on how to identify this and how you can sort of manage it going forward, and now we're waiting to see, fingers crossed, we're going to get some resources to actually study it in a more quantitative level, and then really the results can churn out some recommendations there. That's one of our big research projects.
Yeah, it seems like there's so many different ways people can kind of come back from the brink, being burnt out or so stressed they're. But I know that in the meditation community, it's the same exact story, where, and I won't say any particular meditations here, but where two that I'm thinking of, we're making the claim of, well, if you are burnt out or stressed out or suicidal or anything, if you start meditating, then everything's going to be fine. Well, there was some severe backlash on that, because for some people that does work beautifully. But then for other people who go to that as kind of almost a panacea for whatever they're trying to fix, and that's like, I've been doing this 6 months and this hasn't done anything. And then, but there isn't any way to say that didn't work. It's not like taking a drug. It's not like saying, hey, Xanax didn't work for me.
Right.
But instead, they're just kind of 6 months down the line, and maybe even worse, when they could have been having a better treatment of some kind or a better activity.
It's very tricky, because what works for me, like I said, may not work for you. That thing may work great. And that's where, talking about what the numbers do and what the numbers mean and how they may or may not lie to us. 85% of people responded to this thing. It's great. We're still missing 15% people.
Right.
And what do we need to do for that? There was a study, it was a study that I was on that I was very proud we did this work coming out of Richmond, and we did groups of individuals who had terminal liver disease diagnoses. And we identified small groups of people, and the participants were the individual with the disease or disorder and their primary caregiver.
Okay.
So whether it's their spouse, their sibling, whatever. We brought them in and they were assessed on quality of life and then affective symptoms, and we led them through 6 weeks, 1 hour a week, of not group therapy, but of a supportive and semi-structured avenue for them to talk and process the things that are going on. And then we worked with adaptive Tai Chi, so some physical mindfulness activities, and gave them some home meditation mindfulness activities. And at the end of the 6 weeks, these patients demonstrated a statistically significant improvement in quality of life scores in both the patient and the primary caregiver.
So I'll chirp in on this one.
Yeah.
Because, okay, so I've been teaching Tai Chi now about 35 years. And for many years, we've talked about how our students, when we have taught in elderly communities and assisted living communities, which most of us in the group that I'm in that do this have been doing for a long time, we've always said, wow, their balance has improved. We're not seeing as many falls with these people. They're moving up, getting up and moving around and doing a lot better and everything. So we've sort of known that for years. Then that big Harvard study came out. And so finally we were able to say, look, here is a big study now
Right.
from Harvard. It's not from Joe Blow University or whatever, but it's from Harvard, and they took the time and they had thousands of participants and everything. And so it was so good to see because virtually in every case we saw improvement
Right.
with people. And by the way, it's not just elderly people. A lot of times people get that image of old people in China doing it in the morning in the park or whatever.
Sure.
And that's carried over as kind of a mystique here in the same way yoga has. And the truth is that there are many people, like I have a class that I do regularly at our dance studio, and it has people that are in their 20s doing it.
Mm-hmm.
And so I think it's back to that, does it work, and does it work for you? That's really the bottom line. Before we get too far from it, I wanted to make sure, you were talking about your friend who's is or was an officer.
Yes.
And I wanted to go ahead and give him a plug, so if anyone's watching, they can maybe connect up with him. What was his name once again?
Christopher Scallon.
Christopher Scallon. And the thing that he does, the benefit, the place is it?
Actually, mark this, circle back to it. I'll take a break. I'll look up what it actually is. I'll give you the information.
Okay, yeah, because that would be a great thing to plug. It sounds like, give him for anyone listening, it might be somebody who'd be like, wow, I could use that.
He would love that.
It'd be perfect. So I remember years ago, before we go there, let me just make sure that I cover the bases with the research that you're doing, because you said what you just described was one of the projects
Right.
that you've been doing. Now, are there others? Are they too numerous to mention, or are they?
There's one project that we're looking where we're taking sort of the similar concept of burnout and vicarious trauma. That's the term we're using for when people are not the identified person one or patient of the actual trauma itself, but the caregivers or the forensic providers who have to provide support for that. So vicarious trauma is not just in the forensic community, but we see it in our medical practitioners as well. So we have another study that we're looking at right now in medical providers, and that one's currently in study. And we're looking at the levels of vicarious trauma, factors that lead to burnout in medical providers, and how it's impacting their perceptions of patient care, and what we can do to sort of bolster that. So that one's undergoing at the moment.
Yeah, and I was going to, playing with that one, and then the one you mentioned before, something that had occurred to me, and it occurred to me as far back as whenever I first heard about dentists and doctors having the highest suicide rate.
Right.
And I'll ask you this, and you tell me if there's any truth to it at all. I always felt that if you're in a profession where you have to, even in a loving way, create pain for people, and if people are coming to you and going, I really don't want to see you, but I gotta.
Yeah.
And if that's going on for years, and you have the feeling of, I'm not really being respected or wanted, or they don't want to see me, or there's some really bad mojo going on, or boy, that person was really screaming when they left, or whatever it is, do you feel, because I know in the dance world, when I'm teaching, people come there willingly. They're happy to see me.
Right.
Totally different experience than, hey, we got to take this tooth out.
Yeah, cupcake bakers do not top the list of people with high suicide rates in that profession. But there's these, and I think there's a number of factors that play into it. And one of them is, research has shown that that's sort of a component of it as well. People who, they do that for a living. But the stress is the other massive component of it. Because when you do, so if you're doing a dental procedure, it's someone's face, it's someone's mouth, it's soft tissue damage possibly. How can it affect the way that they look and perceive? They're very self-conscious. There's the pain amount as well, in addition to the stress that you're under when you actually perform these procedures. In addition to that, the high percentage of whatever the word is going to be, litigiousness, how litigious the society can be. So if you're in a position where you could be sued easily, there's a risk and stress that's associated with that. Doctors and physicians who may be causing pain or under stress to save a life, treat a condition. And especially if you're in a field, neurology is always towards the top of the list, because so often we're dealing with conditions for which there is no cure. If someone comes in with, I have an infection, you treat the infection, hopefully it clears up. I broke my leg, you set the leg, hopefully it heals up. But when someone comes in with a condition and we have to tell them, there's no cure, we'll try and help you manage this, or this is a terminal process, or things like that.
So there's no rainbow.
Yeah, the fact that as a field, pediatric oncology even exists right? Just the prospect of that's a thing we have to do, and there are professionals who have to do that on, day in and day out. Very stressful, very frustrating. So there's that. There's the pressure of, every time if you lose a patient, you have to go explain it to family members. Another field just outside of medicine is veterinary medicine. Same type of situation. They don't often get lumped into that list because people think, oh, healthcare providers, and they don't think about veterinary healthcare providers. But just how many puppies do you
Something
have
about
to?
pets, man.
Exactly. So
Isn't that odd psychologically how, I mean, I suppose it's the factor with pets that they're so innocent and they never do anything mean to you or anything,
Right.
and then all of a sudden, hey, now you're on the table dead, and I feel so bad for it, and I wish I could have done something. And
The additional thing that really plays into it that we're finding in the medical world and the forensics world, this real overarching characteristic here, is when you find someone with whom you've made a personal attachment, whether it's directly or indirectly. A lot of times, well, I shouldn't say a lot of times, sometimes you hear people say, I got into this field because my grandmother had X disease, or I had a cousin who had this condition, and I really wanted to understand it, and I really wanted to, well, that's fantastic and admirable, but at the same time, on a subconscious level, every time you see a patient who has that condition, are you now thinking of grandma? Are you now thinking of your cousin? And you have an emotional attachment to it, and is there a threshold and a breaking point? Same thing in the forensics world. The forensics professionals, they go to school, they study, they look at all the crime scene photos, they analyze all the blood spatter, oh, it was this weapon in this methodology, blah, blah, blah. And then if they have 2 kids, the first time they roll up on injured children. World is upside down. This is like the example I give in my speech all the time is raise your hand in the room if you own a dog, raise your hand in the room if you can watch Marley and Me, right? So people, when you have that emotional connection to something, it's sort of, even if it's on a subconscious level, can sort of cloud the lines of how well you can separate yourself from it in an intellectual and academic capacity. And when you're associated with it, you are at risk for having an increased emotional reaction if there's an adverse problem.
right.
See, something that I've talked about a lot with several filmmaking friends of mine is that, like, say you were growing up in 1850.
Okay.
And you had
You're growing up in 1850?
I'm growing up in 1850, and I'll do. I was growing up in 18. I'll do first person.
Sure.
And say that I'm 10 years old, and I have some concept of death and of pain and suffering from my parents who told me something about it, and maybe I had an aunt die and I had that experience. But then maybe I see a dead body. And so I have a very real thing. Maybe I even saw the person get killed, which probably wouldn't be too uncommon in those times, right?
We've taken a dark turn.
We're taking a dark turn, yeah, but a very realistic turn.
Right.
Yeah. So now, there's a very deep reality to the child in the psychology of taking that on and learning it and saying, this is what this is, and I get it, and I'll have to face that at some point, however that's going to be, right? So it becomes part of the identity, part of the worldview. Fast forward to 2019. You have a 10-year-old kid. He's probably been exposed to shows like CSI, for instance, and others that I'm sure people can think of, that maybe portray things in a seemingly real sense. Or maybe he sees a movie, even a Disney movie, where someone dies, but it's done in such a clean and saccharine way that the true harsh reality of it, or what one could perceive as harsh, isn't really taken on or assimilated. And so now, from my perspective, or what I do all the time, we see this in martial arts all the time. Because people go, martial arts, that's MMA. Or they go, martial arts, that's Bruce Lee. And they think of every movie or thing they've seen on television, once again, this vicarious experience, and they say, well, that must be what that is. When in fact, for us traditional martial artists, it has nothing to do with self-defense at all.
You mean it's not all just like Bruce Lee made it look?
Absolutely. That's right. Well, first of all, you got to get the bowl cut.
Right.
Then you gotta...
I tried it once, 7th grade, did not work.
I tried it, and this is what happened. And now I don't know what to do. But anyway, I hope I was maybe a more elaborate concept, but I was trying to frame that because to me that's crossed my mind a lot about how just the way it's almost like we take things on in this highly, and not necessarily tech, but in a way that somehow is trying to protect us or is it's so gruesome, like, hey, little Johnny, we don't want you to see any dead bodies, or if we have you see them, then, they're going to be all dressed up and look very nice for you, because we definitely wouldn't want you to see what happens.
So I'll unpack the statement you just made, and this is the beautiful thing about being a psychologist. You never know what you're really saying, right? So he said, hey, little Johnny, we don't want you to see dead bodies. In that statement, you've already told him that now dead bodies are a thing that exists. Mm-hmm. Even if you don't want him to see them, he now knows it's a thing, right? So being aware of sort of what we're actually communicating, putting out there. And I have two young children, and until I'm able to see the world from sort of their perspective, there are things that I did not pay attention. Go back and watch your favorite movie or favorite television show as a kid, and there will be jokes you totally missed. And oh my gosh, I can't believe this made it past whatever sense or whatever, because you're sort of naive to that concept. But interestingly, it almost, I watch I don't want to get in trouble. Let's just say a widely accessible children-directed animated movie company. Okay? I don't want to get sued here. But you watch one of those movies, and the trope that we joke about is, it's a movie from that company because their parents are going to die. in every movie, that comes up so repeatedly, and my wife and I look at each other and go, I can't believe and the kids are just bopping along. They accept it as a thing. And I heard it from one of my children today. They were playing with somebody, and someone who wasn't really familiar with the movie said, so-and-so's going to go see their parents. And they said, no, their mom's dead. It's a thing to hear from a child, right? So I don't know if you knew this, but interestingly, my master's thesis was on age-appropriate communication. And how you transmit...
I did not know that.
Oh, okay. So it was just an accidental segue.
Yeah, no, perfect.
How you transmit cultural values, familial values, and education on an appropriate level to children. Now, we did it retrospectively, and we did it in the milieu of risky sexual behaviors and sort of the things that people had engaged in. But we evaluated qualitatively their perception of the communication and the factors that played into it that they had with their own parents and caregivers, and how that correlated to their perception of what was safe, what was culturally normal, understanding of the risks that they were engaging in, and how they behaved going forward. And we saw, and it's been supported from some other supplemental research since then, that people who perceived that the communication they had with their parents was on both ends open and honest, and education was being provided at an age-appropriate level. Right? So if you have a child who comes home, a 5 or 6 year old child, and starts asking you about anatomy because there was a little Johnny on the playground, little Susie on the playground told me about this, and that. It's not time to pull out the medical school textbooks and walk them through the reproductive system and blah, blah, blah. But there's a way to approach this where the child will understand that you're being communicative with them, you're participating in active communication, you're not saying, that's not a thing, that doesn't exist, whatever.
Right, you're not making it verboten, so
exactly.
It's like, now I really want it.
Right, yeah, because it becomes the forbidden fruit. Mm-hmm. But you say, okay, that's a thing, and here's how we feel about it as a family, and here's information that's available, and let's not bury the facts, but also, they don't need to know every particular technical and anatomical process and whatever, and blah, 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 at the age of 6, 5, 4, whatever it is. Mm-hmm. Because that can develop as time goes on, and when you put that in front of children, you can say, this is something that we do, and we're happy to discuss it more going forward, but it's not a thing that we want you to talk about with your friends, but let's talk about it in such and such a way. And it goes across the spectrum, not even just sexual communication, but it was very taboo, and someone wanted to tap into it there, but in the transmission of other cultural values, norms, things like that. Inevitably, at some point, a child is going to experience death in one way or another, whether it's a parent, grandparent, whatever, or an adverse event of some kind. And you walk that line of what's the appropriate amount of information to convey? Are they seeing me? Children see and hear everything. Right. They see and hear everything. Yeah, like I know it because when I'm driving down the road, I hear my daughter say things that I'm like, oh, you were in the car last week when I got cut off. Great, okay. Now we need to tap into that. But making it...
And now I'm driving here with my boss. And that's excited.
But when you're able to take that information and make it accessible to them in a way that they understand, and if it's something that you don't want them to do or repeat, and you want them to know it a certain way, like you said, not making it forbidden, making it accessible, but making it palatable and digestible for them, and having them perceive that they're having an open, honest exchange with you, fosters healthy relationship, And again, in that same study, people said when they perceived those characteristics to be strong, they felt comfortable going to their parents later in life as the complexity of scenarios developed. And there was another correlation where people felt those factors weren't present, they couldn't go to their parents.
See, yeah, to me, that's, and I thought, moving on to this topic instead of the death thing is fine because both are equally entrenched in meaning and about age.
And I'm definitely avoiding making a political statement about violence exposure in the media, so thank you.
Right. Yeah. But, it's there. I mean, there's no denying it. I mean, it has to have some effect. The only question is what degree. And probably each child is different. But the other thing, too, I think, which must be exceedingly frustrating for parents is, well, we've already talked about this as their parents, and this is how we're going to deal with this when this comes up. Because it's not will it come up, it's when it's going to come up. But, by that time, they could have seen 20 porn clips for all we know because they're at school and some kid's messing around with it or telling them or whatever. And so I think the degree of exposure to these things is probably way higher, certainly more so than when I was a kid.
Children are growing up in a different world nowadays than you grew up in, than I grew up in, than my parents grew up in, and it's the things that, and even not, with a sexual context, but just the things that my children talk about, my own parents look at them and go, how do you know this thing? Because it's easily accessible.
Right.
There's been some talk recently in the news about algorithms that are being used by internet media domains and things like that, and how they lead you in the direction of watching certain clips and videos. None could have been more present where one of my daughters was innocently watching a music video of an animated feature film song from some large international corporation, right? And it's okay, they're watching it on their tablet or whatever, and a couple minutes go by, we turn around, and it's the same song, but the video in the background has been contorted to be fire and flames. And so, how did that happen? In 3 minutes, right? So now we have to process this and talk about what that is and whatever, because we don't want that to be nightmare fuel.
Fire and you mean like it was just a scary image?
Yeah, they had taken the same words and music and changed the background of it to be horrific. Satanic, right.
Oh, like satanic, kind of a lot of.
I'm trying to protect our
imagery.
Copyright violation thing by not saying exactly what context it was, but it was something, some animated movie about being very cold and girls, one of them having magical powers that could make ice and snow, right? And then someone had taken the context of the main song from that movie and put those lyrics over top of, instead of it being snow and ice, it was fire and flames.
Okay.
It's a very disturbing image.
So it was a twist. Like it's definitely something. If a parent looked at it, that would be like, "That's not what we intended for them to watch."
Yeah,
and
it happened. It was just the next linked video.
Yeah.
And
so this theory of the algorithms being out there that are doing that is highly likely. You're saying.
Somebody who writes algorithms, that's a level of expertise I can't even begin to tap into. I can spell algorithm, right? I don't know how to write computer code, but I always seem to be finding trends and things that I'm looking at on the internet or on social media or whatever. They always seem to pop up in random places here and there. So
sure,
I don't know.
Yeah, no, it's more than coincidence, certainly. I would think too that even if you played by the book, like if the child came and said something like that to you, still you're going to have for each child this different biology, chemistry thing where, I mean, to me, regarding sexuality, especially, some people are just hypersexual, and then other people, it seems like I have no.
So if I knew the answer to that question, I'd have a pile of money this high, right? So
right. Yeah,
that's the thing, is there's a little bit of a black box here and how that sort of plays into each other. But it goes back to what I was talking about earlier about having this stress diathesis concept. It's the nature and the nurture and how you manage those things. And if somebody is, if for whatever reason predisposed to behave in that certain way, whether it's because they have a syndrome where that's a component of it, or if they're behaviorally being put down that path and things like that. How you can manage the environment. You can't control the biology, but you can control the environment and what's going to be fostering it and whatnot. So in that, we took that opportunity and turned it into a learning environment with it when she stumbled upon that video and said, all right, you have these questions, let's answer them right there. And also being very careful not to project our own emotions into it and say, this was scary. No. How do you, becoming the psychologist again, how did you feel when you saw that thing? Turns out it was no big deal to her, but to me it was like, this was a potential landmine, so make sure we dealt with it appropriately. But that concept of what is someone predisposed to? Are they in an environment that can foster it? And some other research that I've done historically and papers that I'm perpetually on the back burner that I'll get around to when I have free time, which will never exist. But I've written a paper previously on the sort of antecedents that lead or may contribute to the development of antisocial personality disorder, what some people conceptualize as psychopathy or sociopathy. Done a lot of research in that milieu and the sort of what sort of environment plus predisposition, plus conditions, plus that, how does it all, is it a predictable thing? Is there any sort of statistic or some sort of thing, track and whatever you could say, oh, this person's at an X percentage risk to develop that? How do we provide social support so that doesn't happen? And that's really where the core understanding of that stress diathesis concept comes into, is you don't want to put beer into the hand of an alcoholic, is the analogy I'll keep going back to for the same thing. So knowing who and how and why and what you're communicating and understanding all the ins and the outs of that is a big portion.
Well, and I would think that, finding out, the early signs of someone being a psychopath or sociopath would be, the public thing is, well, did they kill some squirrels when they were 10 or whatever, but there's got to be so much more going on.
The other thing is, who's the primary reporter for every child that comes in to see you? Oftentimes it's the parent, right? But you have sort of this myopia of parenting where you see your kid and this is my kid, and they do this weird thing, but it's whatever. Everyone on the outside may go, how are you missing this red flag? How often do you see that? The interview is on the news. They were such a good kid. No, they weren't. Look at all the things that happen here. But you sort of miss that.
It's like denial's not a river in Egypt.
Exactly. So it's a little trickier than it, it's always easier to do in hindsight and from the outside. But it's a little different when you see the big red flags, they stand out. But there's little subtleties here and there that people may miss. And it's understandable as to how that can happen.
Well, I'm sure, once you start interviewing the kid and the parents together, and then not together.
Right.
And you start seeing, oh, there's trends here and not there.
Exactly.
That can get really, man.
We're going to take just a quick little break, folks. We'll be back. Sebastian and Sierp, Dr. Timothy Ainger. Boy, the conversation is cooking. So don't you turn that channel. You stay right there.
At Kyojuteiru Kempo, we believe that everyone has the right to defend themselves and their loved ones. Violence can visit us despite age, race, or gender. Call us at Kyojuteiru Kempo or check us out at kyojuteiru.org. kyojuteiru.org.
Hello, I'm Chip Sebastian. I am the co-host of Sebastian and Sierp. If you've been liking the shows, please click like down below. And if you want to subscribe to our YouTube channel, jump on over to YouTube, click subscribe, and you will get the most recent episodes of our show where we're interviewing all kinds of great and interesting people. So we're looking forward to a lot more shows. Stay tuned. It's rolling. Just begun. And we're back. I wanted to get a little bit more into the forensic stuff.
Okay.
Because I think not only is that fascinating for the audience, but it's just fascinating to me in general. I read the best book years ago by Dr. Emily Craig, who wrote Teasing Secrets from the Dead. And she used to teach down at EKU. I think she's retired now. But, man, it was fascinating. It was all about forensics, and she had worked on trying to piece together a lot of the bodies after 9/11. There were, she went through a lot of these things in the book. What is your experience with that? Is it like straight up police forensic work, or is it?
I think the first thing we can do when we talk about forensics is sort of clarify some of the misconceptions. That when we say forensics, we don't mean, I jump out of my CSI Miami van, I throw on my sunglasses, and then we scream, yeah! And there's multiple, we're talking.
You gotta have that cool name.
And some kind of dad joke pun that I can, But that entire, as a career, as a profession, we're talking about people who do every level of work, and it's not, we show up, we pick up a shell casing, and we use a hologram, and it's cleared up. No. There's chemistry, there's biology, there's fingerprint analysis, there's DNA testing, there's, to a limited extent, behavioral analysis and profiles and things like that. And it makes for really sexy television, but the professionals that I speak with, they get really frustrated because people go, well, I saw CSI, so I know exactly what you do. And
Right. Like I watched House, and I know how the hospital works.
Every forensic professional peer of mine that when they hear a conversation that begins with CSI, they just glaze over and go, okay, I'm not changing your mind.
They're like, am I having chicken or fish tonight?
Right. So, but my experience in that realm, I am not a crime scene technician. I'm not a lab technician. I've been on my fair share of, active scenes, and as I was a first responder and an EMT when I was younger as well. So I've done a lot of responding things like that. But my component was more from the research, the profiling, the analysis components of it, looking at behavioral trends, classifying individuals. And then also there's a component that sort of doesn't get a lot of attention, and that's making sure that victims are being cared for as well, and that they're not getting lost in the mix. Because, we all want the perpetrator to go to jail and this and that, blah, 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 and they do. And then who's left in the wake? So kind of managing from that
like
perspective.
Follow up with them.
Absolutely, making sure things like cases where there's, if there's a terrorism event or a mass casualty and things like that, the little things, like if there's a plane crash, who collects the personal effects of Americans in a foreign country and then returns them to family members? How do we get that luggage, that thing, whatever that, we've collected and processed the evidence, and who returns? That's all wrapped up in the forensics world as well. So as a very good colleague of mine, who by trade is a forensic anthropologist, and he's way smarter than I am, especially when it comes to bones, which are his specialty. He and I are actually in the middle of writing a paper right now. Hopefully it's been well accepted by the time this makes it to airing. But he's done this for a long time. I'm sure maybe you've done some research with regard to like the body farm, Dr. Bill Bass's body farm at the University of Tennessee. Okay, so he did a lot of his training there, and his looking at changes that can occur as far as decomposition progresses, or in different environments, what can preserve body tissue, and how do we take that from a forensic standpoint, and then this is what we now know because we've done it. We've done it in vivo. We've taken a body, we've buried it in leaves, we've put it in a trunk, we've submerged it underwater. What does that look like? And then now we have a crime scene that's similar. How does it line up? Well, what kind of insects are on the body, and this and that. So this is his job. He and I are writing a paper because this is Dr. Jonathan Beathard.
Dr. Jonathan Beathard.
Beathard, yes.
Okay.
So he, in one of his, one of his many international anthropology digs, he came upon this skull from Transylvania. And there was a wound on the skull, but the wound had significant evidence of healing. So this person suffered some sort of head injury, but did not die from it, because we saw the way that the skull had begun to heal around the wound site. Excuse me. So he came to me and said, this is a thing that not a lot of people are talking about, but what sort of quality of life, what sort of changes did this person experience from ostensibly a traumatic brain injury? And so we're tackling it from the perspective, okay, neurologically, what portion of the brain parenchyma was impacted? What sort of viable hypotheses could we come up with? What sort of mechanism of injury? So we've done a bit of a deep dive into weaponry that was available at that point in time, mechanism of injury, skull fractures, fusions, what sort of happened there, and then what do we know culturally about this region? What type of people were they? Is this a warrior? Is this a farmer? Whatever. And we're starting to piece together, and again, it's all speculation.
And what time period is this that the
Oh, he's going to kill me because I'm forgetting exactly, but sometime around the 1500s, 1500s, so medieval
so we're
time
talking
period.
about still AD.
Yes. Oh, yes, AD, exactly.
Okay, yeah.
So it's speculation, but using various scientific processes, research known, things like that, we can sort of say, this is a possibility. For what? So I don't think we've stumbled upon the medieval Phineas Gage or anything like that, but sort of looking at this and going, how would this have impacted cultural, his background is anthropology, so he studies people from that perspective. So able to lend what little, my corner of the world that I sort of know about, and how we can sort of integrate this and work together on this. There's a great infographic that I remember when I was in doctoral school, and it was probably the most depressing infographic of all time, but it was a big circle, and it said, when you get your high school diploma, you study all the things to this extent, and then your bachelor's degree is sort of this extent, and then as you specialize and specialize and specialize, you sort of lose focus on all this information, but you sort of, on the history of all knowledge that ever existed, you focus on one thing in your entire career, and you make this much of a dent and expand human understanding. So we're sort of taking our two little dents and trying to force them together and sort of, here's some interesting information going forward. So.
Yeah. It's almost like the self-actualization.
Exactly, right. We're slowly
to that point.
self-actualizing in our careers,
That's
right?
funny. Well, now with the forensics work too, so when for you with forensics, you were saying that your main focus, unlike a CSI guy or would be more of profiling.
I'm going to be very cautious there. Providing research, support, trends, data, stuff like that. I don't want to go out here and say...
Not like I'm an FBI profiler, this guy, we know he's out there and I'm looking,
There's the great media trope of, I'm an FBI profiler and, oh, you're wearing purple shoes, you must have killed 47 people. Absolutely not right. That's not how... There's a lot of research and trends and whatever that go into this stuff. Yeah, things look great on TV because they have to fit into a 45-minute window or 25-minute window.
We got commercials to do, man.
Right. But looking at criminology and statistics and behavioral patterns and profiles and all these things play in, and if at the end of the day I can scrutinize 47 research papers and write 100 pages and this and that blah blah, we catch one bad guy, great. But no, I'm not out there putting the cuffs on people. That was not right.
Well, one thing that I think would be a great question for you too is, what is your take on the since Columbine, what's happened? What was an every 2-year thing or something, and it'd be in the news, a shooting at a school, has now turned into, it seems like every month we hear. What do you, from a psychological / and I know we can get in some touchy areas there, but I just.
Well, it's difficult to talk about from a neutral perspective because it's in the zeitgeist. Which is horrifying in and of itself. So to talk about this from an academic and psychological standpoint and not make it political. Interestingly enough, when I was an undergraduate student, I worked for a brilliant social psychology researcher who was attempting to understand this from a laboratory standpoint. So this is Dr. Lowell Gertner, and he and his co-researcher, Dr. John Iuzzini, put together a research project where they were examining what type of antecedents could cause an individual to aggress against another individual or a group of individuals. Very direct in the wake of Columbine. So they devised a laboratory experiment where they could see if manipulating certain variables would cause an individual to aggress against either the person who was aggressing against them, or if there was an easily identifiable characteristic that would assimilate them, aggressing against the group. And they were seeing that was happening. So if there was some way that they could collect these people 1, 2, and 3 together, this individual may aggress against all 3 people instead of just the one person who was being mean to them. So that sort of, I think it goes back a little bit farther than that. And we can talk about things like, well, we have access to more media and more things are being reported. That's true. Everyone with a cell phone in their pocket and a social media account all of a sudden is a reporter now.
Sure.
But that's not what's causing this. Everybody who has a social media account and they're anonymous online, there's a lot of philosophy and theory being kicked around on the internet about when you you put on this veil of anonymity and you go online, and because you don't have to have an interpersonal reaction, people get very disinhibited and they say things online, they text things, they whatever, that they would normally not say to another human being because the interpersonal component of it has been removed. There's been a lot of prolific court cases recently where there was an individual texting instructions on how to kill themselves to another person, whether or not they would have the ability to say that face to face, but they said it via text message. And they were disinhibited enough to the point where they could say those types of things. So when people are they get pushed to the brink a lot easier because they have access to this. This is not the internet is the devil conversation. It's not. I think it's a number of factors. And again, if I knew what it was, I would scream it from the rooftops and we'd put an end to it. But there's just so many factors at play. And it's, we have more information, we have more accessibility to resources, to knowledge, to other people with an increasing amount of connectivity and a decreasing amount of individuation. Something in the soup is spoiling the mix here.
Well, yeah, because with the example you just gave about the texting the instructions, it seems to me that if it was 1950 and if somebody said, well, I'm kind of suicidal, and then a guy overhears the person say that, he could find their address and send them, a typewritten letter on an Underwood saying, here's how to kill yourself. And it would still be the same intention, whatever that was.
But that's a lot of energy. That requires a lot of energy. It requires, resources and access. I need a stamp, I need a letter, I need a pen, I need a typewriter, or whatever. Versus
from a legal standpoint, it would be about intention, right?
Bad intention.
Yeah. And so, I don't know. That seems, the disinhibiting due to anonymity online seems to be an easy answer that doesn't seem to satisfy totally.
We have this discussion now from the family perspective as well, and we talk about, at what age do our kids get devices with internet access? Do they get cell phones? Do they get tablets? There's no right or wrong answer to this. Well, there's probably a wrong answer that's more obvious. You don't give them a cell phone as they come out of the womb. But we're doing when they're used properly, these things are incredible tools. We went to buy new phones fairly recently. It's like, I can't believe a phone costs this much. We didn't buy a phone. We bought a computer. We had a computer that fits in your pocket, right? So, I have probably spine diseases from lugging 65 pounds of textbooks around because the textbooks were, this is the knowledge I have access to. Maybe the library, that's it. Now, this is the knowledge I have access to, and it's all the information in the world. And I'm going to write a paper on, the Saharan subcontinent. Let me get in a chat room with someone from that culture and ask them all these questions rather than flipping to page 400 and reading this paragraph.
Right.
Amazing.
By someone who probably wasn't from the country to begin with.
Right. Fair enough. But there's a double-edged sword to that, and sort of at what age, we talked earlier about when did the frontal lobes develop? When did we have the full control of behavior and inhibition and affect and all that type of stuff? And not until we're adults. But now we have school curriculums being designed around having internet access. Schools are giving tablets to students because we want them to have access to X, Y, and Z, and that's great. But at the same time, the level of supervision that's required to make sure your kids are not in the back of the classroom plotting the next attack on the tablet that you've given them to do a history paper or things like that. So it's a very slippery slope is a little morbid, but I'll say, there's a lot of the technology is also outpacing our ability to sort of legislate and control it at the same time.
Well, that's what I was going to ask about too. It seems like the tech has just so far superseded the governance.
Right.
I mean, really, there isn't anything online in terms of, if you as a parent say, well, I don't want my daughters watching that. Well, you pretty much have to go on and say, well, I'm going to put a thing on there saying no access.
Right.
Oh, but we want to watch Hannah Montana, Daddy. And then say, okay, well, you can watch that. But this, you won't be able to get into these sites, so don't even try.
Well, we talked about earlier about what's the forbidden fruit, too. And how do you access this and explain to them what you do when I'll just take their phone away.
That doesn't work.
Right. The most creative people are the people who've been told they can't do something or you've taken something away to inhibit them from doing it, right?
Yeah.
And when you see the ways that people communicate with each other and create and smuggle contraband in a jail or a prison, right? When they should not have access to anything, and they'll just come up with a really creative way to find it or make it or do it in another way. Right? That's the best microcosm for this is like when you're in the most restricted environment, people are at liberty to be as creative as they can possibly be. With tech, we have no way to do this thing. They'll invent that way. Some guy just flew a jetpack across the English Channel last week, right? Because we said can't do it, so they did it. Tech's the same way, and I don't want to say, technology is bad because it's not. Technology is amazing, but we're at a very interesting point in society where we're, like I said, we're sort of outpacing, the creation is in such a boom that it's outpacing our understanding and control of it. If you sit down to create a game, you'll say, well, these are the rules, and this is how you'll play it, and I'll regulate it, and I'll beta test it, whatever, and then I'll make it available. That's not the way that we're developing apps and programs and things like that nowadays. People say, it works, put it out there, and we don't know anything about it.
Well, in human cravings, I don't think it really changed. And, of course, if you have something that's visual or auditory that somehow supports that, like whether it's, porn or if it's, some guys like, hey, I'm really an aggressive type, man, and, I'm going to watch this video of two guys fighting in the street, and then I get more aggressive. And then, now I'm wanting to watch, here's on the dark net, we've got some dude who's doing snuff films, and
Right.
I'm watching that. Then all of a sudden, wouldn't it be neat if I did that myself? And and then
It was very funny from us, from the adult perspective, because every year or two, some task force would come out and say, here are the 12 apps, here are the 12 programs, here's the slang you as an adult need to know that your children may be using. And, a couple years ago, it was what all the, ROFL, LOL, what all that stuff, because parents were completely closed. And those of us who were sort of on the cutting edge of that culture at that point in time went, these idiots do not know what they're doing. And nowadays it's true. We have internet task forces coming out saying, do you know these 14 apps that your children may be using? And you laugh and go, it's not 14, it's 65. You've just found 14 of them. They'll just find another way to do it, right?
Right.
So it's interesting to look at that from both the consumer and also the parent perspective.
See, it seems to me too, there's something embedded in our psychology that really, it must have answers to whatever's going on, must create an answer, even if all the facts aren't in, or maybe I don't even need facts. 200 years ago, it might have been like, well, this person's acting weird over here. We don't know what's going on with them. Must be Satan.
Right.
Satan's taking them over, and God, let's get them out of the village.
We like a good solution.
Yeah, like a good solution, because we can't sit in the mystery of whatever it is. It's like we got to resolve this somehow. And I'm sure that's an evolutionary thing too, in terms of we got to get this done.
400 years ago, we cured, mental illness and a modicum of physical diseases with leeches and bloodletting, because we had to get, the blood ghosts out of people.
Right.
And then 200 years ago, it was, we'll just give them some laudanum. Here's liquid opiate and opium.
And then
whatever.
it was frontal lobotomy.
Right.
And it was
exactly.
Yeah.
So, who's to say that the great solution we have now is the all-encompassing one? So that's where, making my dent on the understanding of the human psychology and functional neuroanatomy and changes over time. What can I contribute that will help increase our efficacy, increase our understanding, the care that we're providing? And, if in 100 years they're looking at me going, well, this is just leeches and bloodletting, but something I did helped further get us to that point. It's the amazing thing about being here at UK, and I was pleasantly surprised when we came here, and I was very excited to get this position that I'm in now. It's a major academic medical center. We have an incredibly diverse faculty from background, experiences, training environments, people who come from all over, who've trained in specialty clinics elsewhere, and then come here and are provided with the resources and the opportunity to attempt clinical trials, new procedures, whatever, and a faculty that is so willing to work in a multidisciplinary perspective. So it's not, I saw Dr. Smith over in this, and then I saw Dr. Johnson over here, and I don't care what they said or whatever. It's, no, we work on this team and we come together and we can sort of multitask these problems from a diverse perspective. It's one of the great things that they do on the epilepsy team here. So I'm incredibly fortunate to work with this really powerful and incredibly brilliant people who work on the epilepsy team. My role is to do cognitive testing. Right? So we'll look at it and we'll say, here's an individual who has X type of epilepsy, this intractable condition, perhaps it's not responding to medication. Where is it coming from? Well, they'll do the EEGs, they'll get the MRIs, the SPECT scans, the PET scans, whatever. They'll bring that. My job will be, let's run you through a gamut of cognitive testing. Are there any clear patterns of weakness that are presenting one another? And then when we all get together at the table, we'll have the nurses, the techs, the neurologists, the epileptologists, that we'll all sit down together and say, okay, imaging showed this. Hypometabolism showed this on this scan. We saw this on EEG. Cognitive testing showed this. We're fairly certain that we can localize the deficit of this particular region. Let's do a procedure and see if we can actually map it and say, yes, we are noticing on the brain parenchyma itself there's problems in this. And then based on that knowledge, we can go to the neurosurgery team perhaps and say, here's a good candidate for some sort of surgical intervention. Here's 4 or 5 options for that. You can do this, 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 and this. And, in these dream cases, we have people who come out of this after the testing and the analysis, and they say, I'm epilepsy free now.
That is just mind-blowing.
Right. And it's because all of these jobs, it'd be really hard for one practitioner to do all those jobs. But because we are able to communicate, and here's a boost for technology. The things that we can use it for in medicine, the way we can communicate with each other, where we can pull records and look at things and get together in these multidisciplinary teams and share perspectives with each other. It's a beautiful thing.
Yeah, undreamt of even 30 years ago. The way it's, it's just crazy. A good friend of mine who he actually passed on from Parkinson's, but he had that operation where they went in and put a
deep brain stimulation.
Yeah, exactly. And I don't know if it extended his life, but it definitely gave him more quality of life in the last 7 or 8 years.
It's something we pride ourselves on that's going here at UK. There's a colleague of mine, and she's chosen that as one of her sort of specialties, and she works on that multidisciplinary team that examines movement disorders and Parkinson's disease. And the way that I work with epilepsy transplant care, she works with movement disorders and Parkinson's, and they do pre-surgical evaluation for deep brain stimulation, and that's her expert niche as well. And we just want to make sure that we're able to sort of work and address all these things. We could easily hide in our little rooms, do our testing, send a report, whatever, but it's better for us and it's better for the patients to get out there and work with these different divisions, departments, and bring our knowledge to them and do this exchange. Exactly.
Yeah.
And it fosters research, and research can foster breakthroughs in treatments, medications, whatever, better understandings, and then we can put that out there and share it with the greater community. And there's really exciting things happening here at UK that we're just going to take to the next level for everyone.
Speaking of your research, have you, you don't have to name people that are funding you or whatever, but have you been seeking more funding for some of the research you've been?
There's the one big research proposal we put in for the forensic study of wellness and burnout and those sort of factors. So we're awaiting hearing back on some grant funding that we put in for there on a national level. Some of the smaller projects, we were successful in getting a small grant through funding resources available for the faculty to study those factors in medical professions as well. We just put in another proposal. One of my colleagues put in a proposal for the technology and telemedicine approach. So we're putting in applications there.
So the wellness and burnout, you were talking about that in terms of the forensic burnout
We have
situation, but that
concurrent
sounds like
studies.
it's more far-reaching than just that, right?
We have the forensic one, and if our proposal goes through, we'll be lucky to do that on a national level and look at forensic professionals. But we have a pilot study that's running right now where we actually have a small amount of funding that we're looking at medical professionals here and whether or not they're experiencing those factors as well. So both of those are currently funded, but I mean, I'm never going to say we can't use more funding because we can always use it, because that just means
More research, the better.
More research, more protocols, more this, more that, more treatments. Yeah, exactly.
So for those who might be listening out there, if you are an agency or an individual who would like to fund, please contact Dr. Timothy Ainger here at the University of Kentucky. He's got a lot of research going on. The wellness and burnout research that's going on, of course, is a huge topic in a lot of different fields, and that can do nothing but help the many people who are in need of that treatment. Sebastian Sierp, we're going to be right back. Hang in there. Hello, I'm Chip Sebastian. I am the co-host of Sebastian and Sierp. If you've been liking the shows, please click like down below. And if you want to subscribe to our YouTube channel, jump on over to YouTube, click subscribe, and you will get the most recent episodes of our show where we're interviewing all kinds of great and interesting people. So we're looking forward to a lot more shows. Stay tuned. It's rolling. Just begun. All right, folks, we are back here at Sebastian Sierp once again talking with Dr. Timothy Ainger, clinical neuropsychologist. He does a lot of stuff. I mean, I've been blown away. I can't believe it. We were talking at the last clip about, the funding for the many different research projects that he has. He was saying, if you please contact the University of Kentucky College of Medicine instead of him directly. That's probably even a better thing, and they can put you in contact with the proper people so quality research can get funded. We had also mentioned earlier about the friend of yours, the friend.
So the three of us that work on this, the forensics research, myself, there's Dr. Amanda Farrell, who's out of Marymount University, and Christopher Scallon, and he has Survivor Mindset LLC. That's his consultant.
Survivor Mindset LLC.
And then he also is with Chateau Recovery. Is his other pet. Chateau Recovery.
Chateau Recovery. So for those who are interested, is there a good number for him, or should they just look up?
It's Googleable.
Okay.
Yeah.
So it's Googleable. So look up him, and especially for those who might be out there who could use that service. Maybe it's not you, but you know of people. Please send them to him, and sounds like a great effort they're making. I wanted to, with the neurological side once again, When just things start to happen neurologically, like say people are starting to feel pins and needles, is that something? I mean, that's more peripheral nervous system stuff, right?
Sure.
But if it starts with that, would it lead on to other things, or is that?
Possibly. The question is going to be why.
So it's just still it's just so.
If I sit funny on my hip for a long time, I get pins and needles and it falls asleep. Okay, that's because there's a reason for that. There's a reason. Is it because there's sitting on a nerve funny, or there's reduced blood flow or compression stuff? But if anyone has any sort of concern as to why a thing is happening, we could talk hypothetical and say, oh, it's because this disease process and that does it. Mm-hmm. A qualified neurological provider will be able to, first of all, clarify, and people who do these things for a living, you can come in and say, I have this symptom, this symptom, this symptom. They go, okay, it's because of this and it's nothing. Or they can say, oh, all right, well now we're going to be concerned for, is it this, and let's run a test. Is it diabetic neuropathy? Mm-hmm. Is it a peripheral nervous? Is it fibromyalgia? Is it carpal tunnel syndrome? Is it the onset of Parkinson's disease? Is it ALS? We don't know. So we could speculate it could be this. And of course, everyone who's watching this is opening another tab and going to WebMD. Do I have these right? And they say, okay, I either have a headache or brain cancer. Right. So I apologize.
Right, we don't want you to do that, folks. Don't freak out just yet. Yeah, you might be all right, really.
The disease inception that I just caused across the internet. But the point of that was, the people who are professionally trained to assess these types of things, they know parsimoniously how to get the data and the results that they want. And they know what tests to order, what tests to not order, how to be responsible with that sort of thing. And I know it's very frustrating. If you're concerned about something, you want to get in to see a specialist, and they, do this and go see this and get that. And we touched on this earlier. And it feels easy to get lost in the process. And because I'm one of the steps in that process a lot of times, that's why I like to speak with people and talk to them about, okay, where have you been? What have you been told? What are they looking for? And how do you understand how this is conceptual? And I walk that tightrope of not giving people more things to go home and freak out about, but also, do you really understand why you're doing these? Because it does a number of things. It has people, keeps them engaged in the process, makes them consciously aware. They become informed consumers, as I've said probably 14 times now. They can, become their own personal advocate. There's ways that they can get involved. They can look up research, be aware. And if it's something that they, we're suspecting this, there may be lifestyle changes that they can just begin immediately. Monitoring things or getting an extra test done on their own or whatever, empowering people to become participants in their own health care. And we see every now and again, we see people who've just had, by virtue of, Lexington is a bustling town. There's a lot of people here, there's a lot of activity,
Don't say that too loud.
We don't want anyone to know.
For a long time.
That's Lexington is. It's a spot on the map.
No. It's hillbillies. We don't know, and it's nothing. No.
But we
stay in L.A. Stay in New York.
Oh yeah, well stay there for sure. Unless you've got really good Vietnamese food, bring that. But we have. There's a lot
bring me some raised pizza from New York, would you?
Somebody with a saltwater bagel, bring that to me. I miss that. There's a lot of activity around the university, and we those of us who live and work here on a daily basis, we get lost because we have access to all this technology, all this fancy stuff. And then your perspective gets changed when someone walks in the door and it's like their third doctor's appointment ever.
Right.
And you we were talking about this with technology earlier, you look back and you go, how did you miss all these things? Well, because they never had access to that information or knowledge for one reason or another. Mm-hmm. So then, you can't expect those people to immediately, when you say, you have this extremely rare condition known as blah, 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 and the interaction of this and this will fix you right up, boom. Think they're going to get that? Can I talk to a patient who has never had access to medical care, who has 4 years of school and then had to work to support their family their entire lives? Can I talk to them using esoteric medical lingo?
Back to the age-related thing, but it's more of education-related or understanding-related. And education may be a bad word for
it's that. Not speaking down to people. It doesn't mean anyone's less intelligent than you. It's making that accessible. Yeah. If my friends who are brilliant computer coders call me, and it's like when you call the IT support and they talk to you like you're an idiot, and you go, okay, well, I didn't study information technology. I can do a lot of great things in my life, but could you please
I wouldn't be calling you if I'd studied it.
How do I make my printer work? And they go, well, you need to, bypass the server. And I don't know, you could be speaking another language for all I know. Exactly. So it's a way that you can empower people and inform people and make them aware, but also make them feel like they're valued and they're an active participant in the process.
Well, it's really the essence of teaching, isn't it? I mean,
Absolutely.
because so many people are expert in something, but they can't teach it all.
That's right.
And just because you know something certainly doesn't mean you can impart it to someone who's really wanting to know, especially if it's a health issue. I mean, that's a big deal. What role does sugar play in the disintegration or the affecting of nerves? I mean, is there, because you hear things in the media.
Right.
But I mean, have you seen that clinically where, this person shouldn't be eating ice cream? And I'm not talking about the diabetic aspect of it. Just
Listen, again, we touched on this, and again, I'm not an endocrinologist, so I can't give you the full biophysiological process. And someone out there who is laughing at me right now. That's why I refer to you, endocrinology. But I kind of touched on this and said everything that you put into your body has an effect, positive or negative, one way or the other, right? And when you roll that into what we said earlier about how environment, genetic predisposition, everybody's got different metabolisms. Everyone's got the genius weight loss cure, the genius, just do this, this, and this. We've seen all the fad diets. It's Atkins, it's carbs, it's protein, it's caveman, put butter in your coffee with coconut oil and drink this. Again, what works for you may not work for me. So, sugar as a whole. There's the people who say, well, it comes from the earth, can't be bad for you. Well, everything in moderation.
Yeah, arsenic comes from the earth.
That's exactly right. So you want to look at anything that you put into your body, what's the effect it's going to have. You said not the diabetics, but that's a legitimate concern as well. Because if you're not producing insulin and you can't combat the effect that sugar has in your body, so that's a big red flag for us. When we see somebody who has out of control diabetes, unregulated diabetes, or poorly regulated from one way or the other, it's going to cause cerebrovascular changes, and it's going to cause cognitive complications down the road. Whether it's acute cognitive changes from them having incredibly hypo or hyperglycemia and they're in some sort of altered state of consciousness, or it's 20 years of rapid cycling, 50, 400 back and forth. All those can have an impact as well. Sugar on the whole, on the nervous system. You go back to the food pyramid, which everyone's sort of debunked and said, let's not do the food pyramid, let's come up with a new system now. But no matter which way you look at it, food pyramid, food circle, food cone, food triangle, balance plate, the pictures, sugar's always this portion.
Right. Macronutrients.
Exactly.
Yeah.
So look at what you need. My 2 cents, and speaking within my realm of clinical practice, is if you're concerned about it, speak to the person who can talk to you expertly about it, but everything in the appropriate amount of moderation. And if you're trying to do something with your body and you think sugar will be counterintuitive to that process, if you're trying to lose weight and you know that you enjoy the ice cream snacks and that's how you got to a heavy set weight, cut out the sugar, cut out the ice cream, because that's a component of it. But
we don't want to hear that.
And again, it's not that simple. It's not that. I wish it was that simple. If it was, I would just never buy ice cream. I'd weigh 65 pounds, right? It's never that simple. So that's why you need to speak to a professional who can, help you along with that advice and figure out what the best way it is. So I can't speak to the pure biophysiological process of the direct effect of sugar on the nervous system.
What we hear a lot, though, regarding cognitive function with, say, like omega-3s and fish oil, though, I mean, that is very legit, right? I mean, because I know, what we put in our bodies, it has different effects on different people, but I mean, there are some things that probably this is going to be pretty good.
Again, to an extent, right?
To an extent, okay.
You can't take a fish oil pill and then treat your body like garbage and just imagine that everything's going to be perfect, right? It's what you're doing in your
fish
body.
oil, smoke.
The thing that really, exactly. The thing that impresses me, and I gave this talk in a lecture recently, is when you look at the unfathomable complexity of the human body with regard to endocrinology, the lymphatic system, skeletal system, muscular system, cerebrovascular, whatever. It's so amazingly complicated, and so many things have to work perfectly in an infinitesimally, a speed of time that you can't even measure. Things that have to happen. For me to do that, the biological processes that have to take place, the exchange of chemicals, the cognitive energy, everything.
They're already doing it.
Right. It's 10 pages worth of notes to get to that point for me to snap on command, right? So when people say things like, I can't believe this went wrong, I am more impressed that things go right so often. And that goes back to, what am I doing to myself as a body, as a person, as a whatever, and look at all the things that have to go right. How can I best care for that? How do I care for my cardiovascular health, cerebrovascular health, promote healthy living going forward, contribute to longevity, especially when you look at whatever your family history is, things you may be predisposed to. Even neurons and nerve cells on a simple level like that. Things that can contribute to loss of connection or cell death. I mean, the nerve cell in and of itself is wrapped in a very thin, fatty sheath, and that's
the myelin.
The myelin sheath, exactly. So that myelin sheath that's wrapped around the nerve cell is what's responsible for the transmission of electrical signal across the cell body. And when you have conditions where they sort of demyelinate, or when you have a breakdown in that tissue, you lose the activity across that cell body and you lose that transmission. And people go, well, that's just a fatty thing. I'll just take a bunch of omega-3 and that'll boost that problem. That's not really how that works. It's far more...
That's an odd leap.
Yeah, but I've heard that leap, right? It's fat is fat, so I'll take that pill and it'll fix that problem right there.
Yeah,
So,
and there wasn't a moon landing.
Yeah, exactly. And my tinfoil hat and...
Yeah, right. And
So,
it was flat.
it's-
And the Holocaust didn't happen.
There's so many complex processes that play into all these things. And I mean, we could sit here and what we've tapped into is the first lecture of the first day of 4 years of college or graduate school or whatever. Right. So the best thing that I can put down into, what's the 2-minute pitch here is identify the things that you're putting into and doing with your body. How can you help promote safe? I'm not telling people to not go out there and have fun and do things that are great, but you know what? Wear a helmet, put down the cigarettes, and simple things that you can do, and that's kind of what we're preaching here.
Do you feel that just on a psychological level, like with Jung's shadow, that people, because so many people that you see acting out all these behaviors that they know are horrible for them, people are told time and time again, and when I say people, I mean myself too. I mean, I do things that hey, that's not too healthy. Probably not as much as most people, I don't think, but I do them. Mm-hmm. And the thing is, do you feel like there's this part of ourselves that we have hidden, repressed, or denied that is kind of rearing its ugly head and in a way saying, well, screw you, I'm going to smoke. Well, to hell with you, I'm going to, you know what I mean? Because you see people going, well, it's not going to happen to me, or hey, it's not going to happen to me, or...
You're talking about a little bit tapping into a psychoanalytic theory or concept called the reaction formation.
Right, reaction, exactly.
Some people refer to the reaction formation as the love of the opposite or the desire for the opposite. And I sort of jokingly say, to my wife or to my family member, don't tell me to do that thing because then I won't want to do that thing, right? So it's sort of, there's a psychoanalytic drive there that makes us, I don't want to say curious, but sort of that, because I was told not to, now I want to, or because I was told to, I don't want to. Mm-hmm. So, but again, there's a difference between explanations and excuses. So, and this is when you sort of look at things from a psychological perspective or from a forensic perspective, it weirds people out when I say things like, I don't endorse what you do, but I know why you did that thing. Mm-hmm. Especially when in like the forensic realm. What do you mean? You totally support why they did that, committed that crime? No. But I understand how they got to that point. And that's not an excuse, but it's an explanation. And we can work backwards and say, okay, whether you're buying into the Jungian shadow and the concept of, the psychoanalytic theory behind that, and, Freud's libidinal pools and the id and the ego and the superego and those types of drives, or you come at it from a pragmatic experimental behavioral perspective, oh, you were conditioned to do that, you were trained, you were taught, whatever. At the core of it, there has to be a way that we can say, let's encourage that behavior to not happen, or let's understand what factored into it so we can avoid those things. Mm-hmm. So there's when you come from a point where you start analyzing on a deeper perspective what's driving things, you can look at that, and that's helpful, but as a neuropsychologist, we tend to not really go down that avenue because we're looking more about acute care and going forward. And how can we manage things? So I'm not saying that psychology is not important. Psychology is extremely important, but we don't do therapy, even though we all have some background in it from our licensing and graduate education. So if there's something we feel like there's a behavioral component that we could really benefit from some targeted support or behavioral therapy or something like that, I'll reach out and we'll make that referral for a patient. Say, we're going to manage all the neuropsychological stuff, but there's a real behavioral aspect to this. And here's what I think, and why don't you take a look at it, and can you help this patient manage it in that way?
Mm-hmm. I mean, to me, it would seem like an incredibly important issue, because if there has been a behavior or behaviors that have led to cognitive problems, mm-hmm. or something akin to that. And then, but the person doesn't even realize they're really doing it to themselves, and all of a sudden it's sort of brought out a shadow through some process. And then now they don't feel like they need to engage in that behavior as much. And now the cognitive healing can start through what on your end you're doing with them. You see what I mean?
At its core, the process of psychoanalysis is to foster and overturn in the sense like you're overturning a stone, not like flip it over, but foster a deeper understanding of the human psyche, the individual human psyche. So that is basically when you remove all the roadblocks that are keeping you from processing a deeper issue, you can begin to learn and move forward with that information. Whether or not people are out here saying Freud was nonsense, Jung was nonsense, this and that, I follow these different. The root of it all is taking a deeper understanding of how we got to be where we are so you can foster a change going forward.
Right.
And that's the deeper understanding, and it's having a better knowledge and a deeper conceptualization of what's going on, which is exactly the same thing we're talking about even from our medical perspective. Mm-hmm. You can't become actively engaged in changing the process until you know the process, right?
Yeah, and actually apply it,
exactly.
Not just have kind of a first year psychology student, we're down at the pub.
Exactly.
Having
watch this,
talking about
watch
Freud
this
and
illusion and yada yada. Right, exactly.
Yeah.
So there's, the core of this is getting a better understanding and becoming actively engaged in the process is something I'm a major proponent of. I want that to be a thing.
Like usefulness, in other words.
Absolutely.
Practicality,
Right.
utility.
Right.
Yeah, gotcha. Do you have anything else you would like to add about your own research or anything else? I feel like we could sit here another 2 or 3 hours, but I know you've got a family to get to. I've got my wife to get to.
I've got to be back here in 7 or 8 hours for work. So
I was wondering what that sleeping bag was doing over there.
That's right. Change of clothes in the car. No, we're really. I think.
What would you like to see in terms of your own research and funding? I mean, I know that the time's a factor because you're a dad and a husband and everything,
right?
All that, but I mean, in terms of if you had somebody say, "Hey, we actually heard the show and we want to give you this money because we think that research is important."
I hate money. I do. I understand.
Sets up a lot of cognitive problems.
I have a lot of cognitive dissonance about money.
Cognitive dissonance, yeah.
But it's obviously a necessary evil. But I feel like a lot of people, it's an impediment to progress in a lot of ways, and I say that because I know you just made this pitch. It's
and how many drugs are sitting in warehouses that could help people.
If I said to you, we could cure Alzheimer's with X dollars in Y revenue streams, and people believe that, we would, But that's not the way it works, and people get very frustrated with research results, and they say, well, I donated this whole new wing on the such and such, and I gave you this, and you given me what? Mm-hmm. Science it happens as it happens. If we have to follow things the way we work our entire careers for the hopes of a breakthrough. We're working tirelessly with the tools that we have, and if we don't have the right tools, we'll try to make it work another way. But as far as money is concerned, funding research is an incredibly beneficial thing to the greater society as a whole, because nobody's trying to run off with the cash. It's a little bit hard once you can't see behind the curtain as to where the money is actually going. I can appreciate that from a donor perspective, and from the things that I've donated to, I'm going like, oh, I hope we get something out of this. We all did the ice bucket challenge, right?
I did it.
Yeah.
So fun.
It's hard when you can't always see the tangible proof, but from working here with the brilliant minds who work tirelessly, we're learning newer things every day, things that would not be possible without everything from the massive electron microscopes to just a couple extra vials in the laboratory. Things that and we work for the state, and this is an academic medical institution, and nobody here has won the lottery recently, and we're trying our best, and the people here are tireless and trying to find solutions to practical problems and pragmatic things that they can do, and providing expert clinical care. And I am so fortunate to be here. And my wife says, you stop telling people you're lucky, because we work very hard. But I'm very, very lucky to have landed in such a place where from the top down, everybody seems to be interested in allowing professionals to work to the best and fullest of their capacity. But resources are what resources are.
I concur. I feel really good about charities that I'm involved with and funding that we do through the studio. Mm-hmm. We're coming up on the 10th year of
Dancing with the Lexington Stars,
Oh, yeah.
which we do out at the Marriott. Huge fundraiser, always well attended. Raise a lot of money for surgery on Sundays, which some of the doctors are here and kind of spread out over Lexington. But who knows how many people that's helped. Now, I don't know the people, and I don't have the numbers, and I haven't seen them or talked to them or whatever, but I know some of the doctors in it, and I'm like, I know they're good people.
Right.
And so, yeah, it's just been nothing but a pleasure. And I do understand what you're saying, though. It's kind of like, when you drive up to a stoplight and there's somebody saying, hey, I need $1. And you go, man, I don't know. Where is that dollar really going? I'm scared to think about it.
Right.
Do I give it to him or not? But then, you have to think after a while, I just don't care. Just, you know what I mean? Well, because you almost have to adopt that attitude, because what are you going to do? Go around worrying about stuff you've donated somewhere? I mean, it's, so things have to get done.
Well, and there's other ways that you make donations here as well. My daughters are actually and I swear we didn't necessarily do this to them, but they're very passionate. Come Christmas time, they make toy donations to the Children's Hospital.
Oh, that's sweet.
They go out and they say, this is what we want for Christmas, but let's get an extra one for the kids at the hospital who can't, have Christmas at home or whatever. So even if if you're not the donor who can make $1.5 million to this, and this, and fund that project, there are kids in the hospital who need toys, and there are people who need this and that. So there's ways that people can get involved on every possible level.
Now, do you see children as part of your practice as well, or is it just adults?
There's a component of neuropsychology where people specialize in pediatric clinical neuropsychology, and I am not a pediatric neuropsych specialist, but I do have a history of training where I've worked with children and adolescents. Okay. So this is going back to that Dunning-Kruger effect. I know enough to know that I don't know everything. So if there's a referral that needs to be seen, I don't want to turn people away and say, this is, I'm not going to see you, I'm so sorry. But we do have colleagues and resources to whom we can refer them if we feel like something is, well outside of our spectrum of care. So I have seen pediatric patients for things that I feel are well within my wheelhouse, but you got to know what you don't know, and that's the big
because
thing.
like you were talking about pediatric oncology earlier, and I'm sure it'd be the same in your field, where it's just those would be some rough cases.
We have some very brilliant colleagues of mine who are pediatric neuro-oncologists in these rough cases, and they're there as that, somebody has to do that job, and they're there to do that thing. So, I do see some children every now and again, but usually older children, a lot of preteens and adolescents and stuff like that. If there's something that really comes up, and this is the other thing, is I don't like it when people say, well, they didn't know where to go. Mm-hmm. I'm in a position where if I don't have the answer, I'm going to tell you that, but then I'm going to help you get to the person who will have that answer. And that's another part of kind of what drives us is, I don't want to give you false information, misinformation, lead you down the wrong road, whatever, but I don't want to shut the door in your face.
Sure.
So I may know a person who knows a person who can help you with that thing. Mm-hmm. So if someone comes to me and I can say, I'm sorry, I'm not the right person for this, but let me help you get to the person who is. Mm-hmm. I consider that a job well done there as well.
Yeah, that's awesome. So, one last thing.
Yeah.
What do you do to unwind? Sounds like you're running constantly, man. You got two. How old are your daughters?
One is 5, and the other one will be 3 next week.
Did you hear that, folks? So I'll frame the question again. What do you do to unwind?
Let's see. My wife, who also works here at the university, we love music. The kids love music. We tend to we spend a lot of time with the family because that's stuff that's very important to us. So travel when we can. Separate yourself from what you do just to sort of get yourself out of that position. We do a little bit of home improvement work, some woodworking projects and whatnot. In my former life, a long time ago, I used to be a musician, so we listen to a lot of stuff like that. Watch a lot of movies, and spend time with the kids.
Yeah, very cool.
Yeah.
I was going to say, a place you would love if you haven't been there is the Mutter Museum.
Oh, in Philadelphia.
It's one of my favorite places,
Next time I'm in Philly, I'm headed there. Yeah, for sure.
Yeah. My wife and I went there. We were in Marlton, New Jersey, and went across the river. We had read about it, but I don't know if you've been in there and seen it. But
I'm familiar with it.
When you mentioned Phineas Gage, mm-hmm. I thought of that a few minutes ago because there are a lot of similar cases they have. And, of course, in some of these You just have to see it to believe it. I mean, it's.
I
Hey,
just-
do you remember that old medical volume, Anomalies and Curiosities of Medicine?
Yes.
That old classic. It's kind of like that, but in a 2-story museum.
Right.
And
It's let's plug Philadelphia travel because I've not been to. Actually, the last time I was in Philly was for a wedding a couple years ago, and just the timetable did not work out. It was at the top of my list. It's like we've got to go to the Motor Museum.
you would love it. And well, and then if you're into art, the Philadelphia Museum of Art is. And then the Philly Zoo was great. Philly Zoo is the oldest zoo in America.
Growing
Kids
up in
love the
and
animals.
around DC, we were very spoiled by all the National Mall museums that were free. So the first time we ventured outside of DC, so wait a minute, you have to pay to see museums? What's wrong with this? So, yeah, but we are big museum aficionados. Our kids love it. My daughter, if she ever watches this, my older one is going to laugh because she is upset that we no longer live near the science center that she went to when we were younger. We're in North Carolina for a point in time, and she still talks very passionately about this. She says, "We're ever going to go back to the science center?" Yes, we'll take you back to the science center. Zoos and aquariums and stuff like that. We're in a place now. I mean, Lexington is so, again, don't let the secret out, but we can access all these bigger cities around us. So what we don't have here, we can get to Cincinnati Zoo, Columbus Zoo, Louisville Zoo. We can get to the Newport Aquarium. We can get to all these great places, and the kids love it, and we love it, and they're thirsty for knowledge.
It's like you were saying earlier, it's so much a perspective and point of view thing. Because I remember 30 years ago with friends of mine, they'd be like, well, I got to move out of Lexington, man. There's just nothing to do. I'm like, I don't have time to do all the stuff
Right.
that I want to do here already, so, yeah, it's just done nothing but grow. That's what's weird. I mean, even during the crash, they were still building houses and buildings here. I mean, it was just,
It's
if you're out
maintained.
there listening, don't listen.
Yeah,
That's top secret.
It's maintained its quaint charm, but I think I told you before, it's big enough to be a city, but small enough to be a town in a fantastic way.
Absolutely, yeah. A lot of rich heritage here, definitely. And we're so glad you're here.
I'm very excited to be here.
Hey, folks, I think that's going to be all for Sebastian and Sierp. We want to thank once again Dr. Timothy Ainger, not Anger. Ainger. You don't want to go to a neurologist who's named Anger, all right?
Right.
We want to make that clear. Ainger is his name, and he is at the University of Kentucky, and it's such a pleasure talking with you today. We thank you for being on, and maybe we'll do it again, and maybe even take some more topics. Cause,
Sure.
I mean, you have so much to talk about. It's just,
Absolutely,
it'd be
my
great.
pleasure.
So, folks, we really hope you had a great time, and we look forward to our next time on Sebastian and Sierp. Till then,